for government officials from the Ministry of Health, Department of, from the Unit of Non-Communicable Diseases, Dr. Valeria Karibsana, and also Dr. Mwanisano from National Health Insurance. Thank you very much for joining us. Once the RMO is here, we will get to introduce him and he will get to know, but he will have time also to talk with us. With this introduction, I would like to ask my colleagues from CSSC, apart from the Executive Director, my colleagues, the technical team, to stand so that we introduce you. These are my colleagues from Christian Social Services Commission. Maybe quickly they can introduce you, you can hear their voices.
Yeah, good morning. My name is Dr. Peter Benardinagunwa, working as a RMNSCH TB HIV Pediatric Advisor at the CSSC.
Good morning, everybody. My name is Petro Masatu Pamba. I'm the Director of Education Services at CSSC.
Good morning, everybody. My name is Alice Palela, Project Officer from a project called Fighting Inequality.
Morning, everybody. My name is Adam Machalila, Project Coordinator of COVID-19 project.
Good morning, and I'm Dr. Godfrey Kwai, working as a project manager at CSSC.
Good morning, everyone. My name is Asubira Limo. I'm working with CSSC, coordinating a project known as USAID Users Istaha, which is a project on reproductive, maternal, neonatal, child, and adolescent health.
Good morning. My name is Gaspar Matero. I'm the Knowledge and Information Management Specialist.
Good morning. I'm Jafet Wangereja, the CSSC Zonal Manager for Eastern Zone. Principally, I'm supervising all the health and education project at the zonal level.
Good morning. My name is Cecilia Benizetti. I'm the Public Relations Officer for CSSC.
Good morning. My name is King Morubandu. I'm IT Specialist.
Good morning, and I'm Dr. Anton Leonard. I'm Health Policy Advisor of CSSC. But our colleague from FHI just arrived, so we'd like him to introduce himself.
Good morning. My name is Kamal Yusuf Kashoro. I work as Social Behavior Change Communication for Family Health International. Thank you.
Thank you, everyone. Once again, myself, I'm Dr. Josephine Balati, Director of Health Services with Christian Social Services Commission. And with our team now, I would like to take this opportunity to introduce to you our Executive Director, Mr. Peter Maduki, and also welcome him to come and open our symposium. Karibu.
Habari za asubuhi. You know, the Germans are the first people to write our Kiswahili Kamusi dictionary. So I assume that you know Kiswahili. How can you develop a dictionary without knowing that language? So are you sure that you know that? Okay, thank you very much. May I first thank. I hope if I don't use the microphone, you can catch me in your cameras. Eh? Yeah, I'm not very good in using microphones, and my voice, as Professor Koish knows, that it always reaches him perfectly. So, may I thank God first for giving us the gift of life, enabled us to come to this symposium particularly in Dar es Salaam, for those people who are coming out of Dar es Salaam. And those people who are not coming in the city center, also I welcome here at the city center. Karibuni sana. Also, I'd like to thank you for coming to attend this a very important symposium with the theme on health financing for non-communicable diseases. I really appreciate for taking your time and also traveling all the way up to this conference hall at our normal hotel. CSSC, this is an abbreviation of the Christian Social Services Commission, was established in 1992 for the purpose of supporting the churches in this country to expand and improve the healthcare services and education delivery. I'm glad to have my predecessor here, Dr. Kimambo, who was also a leader of Christian Social Services Commission. Thank you, Dr. Kimambo, for coming. We operate with about 900 health facilities in this country. This includes zonal hospitals. We have about 3 of them. One is KSMC, Bugando, and LMC in Arusha. But we also have hospitals at a regional level and also the council levels. So we have a total about 105. And then we have about 102 health centers, and the rest are the dispensaries. So you can see how are we involved in providing healthcare services in the country. And these facilities, they represent about 30%, about almost 40% of the services which are being provided in this country. So we thank for the churches also for establishing those facilities. We have also education. That's why we have education facilities, which are about 1,222, 1,202 facilities, which are from the kindergarten to the university education. Among of them offer education related to the health. So we have a little bit of the extended or enough adequate facilities which can provide health care and education services in this country. Among our strategies in CSSC is to improve the provision of healthcare services, and in particular in the area of non-communicable diseases and financing. And these strategies were developed based on a number of the consultations which are in the country, within the country, and outside. I'll just talk about the outside one. The outside one is related to Dar Hamburg, and Dar es Salaam city, which has a component on the churches in the health provision. So we had a number of consultations. One was the first one was held in Germany, Hamburg. I think if I remember well, it was 2013. Am I right, Sangiti? Yeah. When I had, at that time I had a black hair. So from that time, we have been continuing with discussion. And then we came to Tanzania in 2017, yeah? Then we had that one. And from that time, we started now developing how can we finance the health sector. And then second, we looked on which areas we can work better. One of them was non-communicable diseases. So CSSC developed that strategy and now is being implemented. Through that discussion, as I said, CSSC had improved its capacity in advocating for healthy financing and also for focusing on the focusing on the financing. So we have been involved much as our representative from National Health Insurance Fund has mentioned that we have been always having dialogue and also seeing how can we improve the financing on that area. But also we worked with our friends from AFTA, TPA, THP, so that we can advocate in the government. And CSSC now has programs which are directly on non-communicable diseases, as you have heard from our colleagues who are represented here. But we're also working with the facilities, the health facilities, to ensure that non-communicable disease challenges are being addressed. So we thank all of you who are participating on those programs and also our partners who are supporting those one. We have also engaged on the quality to ensure that you provide healthcare services with improved quality. And we are also thanking the Farmer Access for leading that one. So we thank you for coming. We are so happy having this symposium today because it will help us to sharpen the areas where we can engage more, and also area where how we can continue advocating for addressing issues related to non-communicable diseases. So I'm expecting the discussion which will go on today will help us, CSSC, to ensure that we have proper interventions on the area of non-communicable diseases and areas of support which we can work on. So on behalf of I'd like to thank the last one, and also the partners who are participating in organizing such event. I think it has already shown a success because all are seated, quiet, listening. So I'm sure that the deliberations will also come, very strong deliberations will come out from this meeting. So thank you very much. I declare, before I declare this symposium has been open, may I welcome our regional medical officer. Please, can you stand up? And so I declare when he is included in that symposium.
So, can I stand up?
Yes, 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 doctor.
We are trying to make some protocol issues. First of one, so I don't want to break the protocol.
Oh.
But I'm Dr. Rashid Mfaume, the regional medical officer for Dar es Salaam. It's my pleasure to be with you here. Thank you very much.
Asante sana. Unajua protocol sometimes zinatushinda, kwa hiyo tuiye radhi daktari. Okay. Thank you very much, doctor. So may I declare that this is not just not to declare. This is only an opening remarks from the executive director of CSSC. Thank you very much for listening. There was a protocol issues. Solved, very well solved. We are very flexible. Now we have our guest of honor, who is present here, and may I ask, because regional medical officer is here, may I ask our RMO to come and first of all, say something, because we are in your region, we are in your city, then you should also welcome our guest of honor to open our symposium. Karibu sana daktari.
Aha, 2 days ago. So please welcome to Tanzania, and especially because today we're hosting a healthy agenda. So I'm very much pleased to see you participating in this event. And it's our hope, our sincere hope, that we'll have very interesting experiences. You know, sometimes we study a lot at school, but experiences is the best teacher. So help having experiences, especially on health insurance scheme or issues in relation to how do we finance non-communicable diseases in Germany. And I hope we'll have also a very good experience from our fellow Tanzanians, experts who will be sharing with us also issues related to financing in non-communicable diseases, but in different health interventions in general. So first, before I proceed, let me take this opportunity to officially now introduce myself. I'm Dr. Rashid Mfaume, the Regional Medical Officer for Dar es Salaam. I recognize that, and let me introduce to you also the guest of, there will be a guest of honor from the Directorate of Prevention. I mean, on behalf of the Director of Curative Services, not Prevention, Curative Services. So while in welcoming her, I will introduce her to you. But I'm aware that we have guests from other development partners, like Danida, Meditronics Lab, Novo Nordics, and I'm told that we have other IPs in this sector. After is here. I can see my chief, Professor Kaushik. I recognize your presence, representing also the Non-Communicable Disease Alliances and TDA. CSSC, I also recognize your presence, and please be comfortable that you are all welcome. Master of Public Health students who are here. I competed in my Master of Public Health course, I think 6 years ago. I don't know if I remember 90% of the issue that I was trained at school. I'm not sure. So we can have also, we'll have also some experiences from there. Don't hesitate to provide your experiences, the Master of Public Health students. We have the media representatives. So my task was just to welcome you officially to Dar es Salaam and to this health symposium. But the second task is to introduce you the guest of honor who will provide opening remarks. But before I introduce to you the guest of honor, and it's my pleasure also to say a few things in relation to how does healthcare financing in a setup of Dar es Salaam. We know that the presenters, if it will be a panelist, will be discussing on issues in relation to the national health insurance schemes, but other mode of healthcare financing and non-communicable diseases. But in Dar es Salaam, as the other regions in Tanzania, we also have health insurance schemes that play a great role in terms of financing of non-communicable disease interventions. Having a national health insurance fund as other regions in Tanzania is an opportunity to us for most of those who are in the formal sector. And nowadays we have some packages for those who are in the informal sector for healthcare financing. But also we have the community health fund that is especially for those who are not in the formal, not who are employed, whether in the formal private sector or the government sector. So they have the opportunities, and household of 6 people pay a premium of 150,000 per year, but an household of one person can act as an household who pays 40,000 per year, and that enables him or her to access services from the primary healthcare levels to secondary healthcare levels, but they are adhering to the referral system, existing referral systems. But apart from insurance, we have the private health insurance like AAR insurances. We have insurance, private insurance company, health insurance company like Strategies that are specific to certain employees from the companies or from very specific private sector who can access the insurance, the services on the insurance basis from the privately insuring companies. So we have those opportunities in Dar es Salaam, but still we have this very big group of those who are paying out of pocket. Most of the, especially the urban poor, are not yet insured. They are not involved in any type of insurance schemes. And people think that most of people are living in urban settings like Dar es Salaam, they are insured. The picture is not like that. You find a lot of people who don't have any type of insurance, and you are now advocating them to be enrolled in the different insurance schemes as paying when they are sick. Most of the times, we are faced with the burden of exemptions. So we provide a lot of exemptions just because these clients who are coming to our facilities, they are not insured. That's a challenge to us. And we know the burden, the increasing burden of non-communicable diseases, especially in urban settings like Dar es Salaam. Among the top 5 OPD attendances, you can't miss one of the diagnoses of non-communicable diseases. So that's really a challenge. And the burden has been more significant during the emerging and emerging diseases like COVID-19. That's when we saw even a number of those who were admitted as a severe or critical cases having also comorbidities, mainly the non-communicable diseases, overweight, obese. Most of them are diabetes. So apart from the data from maybe the panelists or presenters will have a time to present and discuss. Yes, we've also been referring data from STEP survey, but I think there is a challenge with the accurate burden of non-communicable diseases, especially in urban settings like Dar es Salaam. So I call upon most of researchers to think of putting more efforts on research regarding to NCDs, including how the burden of NCD has raised, referring to a research that was conducted more than 10 years ago. That's not a reality. Actually, we need updated data on the burden of non-communicable disease, because the actual data will reflect also the actual cost needed, the cost needed to be incurred in accessing the non-communicable diseases. We are very happy as a region that we are implementing the non-communicable disease interventions as per our guidelines, the national guideline for prevention and control of non-communicable diseases in Tanzania. So we have a well-prepared, established guidelines, also that emphasize on the public-private partnership, the other policy guidelines like National Strategic Plan, 5 also, and the other different guidelines are there. So we don't have a problem with how do we implement the NCD interventions as per guidelines, because, and per guidelines and the standards, because we have the available guidelines. So I just wanted to give few remarks before I officially welcome the guest of honor to provide the opening remarks. Because as the regional medical officers and as the region that is as a big population as compared to any other 26 regions in Tanzania, it was unfair if I stand here just and say, welcome the guest of honor without showing you the magnitude and also the importance of having the very effective ways of financing. Here we are talking about health financing in general, not only insurance. And I hope even the costs that are incurred now, when you are saying that the cost for consultation, maybe it says 10,000, is it the actual? So we have the problem with the costing study in terms of the actual cost that at least will recover, not making profit, but that at least will recover the cost that has been incurred in procuring and making sure that the services are available. So with that short few words, may I take this opportunity humbly to welcome the guest of honor from the Directorate of Curative Services, who is Dr. Valeria Mlenga. Valeria Mlenga, please welcome. Can I have claps for her, please? Thank you very much. Karibu sana.
Asante sana Dr. Mfaume. Good morning again, everyone. As I'm introduced, I'm Valeria Milinga, an acting program manager from the Ministry of Health. First of all, I'm very happy to be here, and I thank God to bring you all here. I want to congratulate everyone and all the efforts that have been made into organizing this important event. For sure, this is a very important symposium or a very important gathering, and we are very pleased as the government, and for us recognizing that the country is facing the burden of the non-communicable diseases, which are the mainly ones, the hypertension, diabetes, cancer, respiratory diseases. And we are very pleased to see the efforts that the other partners are also putting into joining the hands with the government. For us to recognize your contributions, for all stakeholders, to mention like private sectors, public institutions, institutions of academic, as well as the donors from the country and abroad as well. With this event and this time, I wish you all a very important moment, a wonderful event that we're all going to learn and discuss and share more on the healthcare financing, on the non-communicable diseases. And out of this important symposium, I expect that we're all going to come up with on the low-cost solutions for the non-communicable diseases care provision without compromising any quality of care based on the evidence-based on care. And lastly, I would love to invite all stakeholders and partners into collaborating with the Ministry of Health into the prevention and control of the non-communicable diseases. I wouldn't want to go further, and with these words, I would want to declare that this symposium is officially opened. Thank you.
Thank you, Dr. Valerie, the representative from the Ministry of Health, from the Director of Curative Services, and Dr. Rashid from the Regional Medical Officer for such a wonderful opening remarks. It has set a tone for today's discussion. So it's time now to welcome Iken from the Hamburg Partnership to give us the greetings from Germany. Welcome, Iken.
Dear friends, we are very, very happy that we have been invited and that we are part of your very important conference. We are partners of CSSC and of other hospitals as well, working together as sister cities since in the medical field since 2006. And since 2013, as Mr. Maduki said, also directly with the CSSC. And the aim of our partnership is that we would like for both of our cities to manage to the well-being of all people. That's our aim. And there are, of course, a lot of different areas where we cooperate between Hamburg and Dar es Salaam. But to us, health is a basic human right. And so we are very happy that we have developed a strong network of different hospitals and with CSSC in this field. And during the Jubilee celebration of the last days, we have signed a new declaration for the next 3 years to come. And we are very pleased that one of the main focus points of the next 3 years will be the field of health. That's all I want to say for now, because my colleagues will continue later. Thank you very much for the invitation, and we are very, very happy to be here. Asante.
Thank you, Iken, for a very brief introduction and greetings from the Hamburg. We are now coming to real business. So, and this event is aired live through our YouTube channel. I hope our public relations officer will share with you the link, and you may share with other colleagues who are not here, who can join us virtually as well to be part of this symposium. So our moderator today will be Dr. Godfrey Kwai, who is the project manager from Christian Social Service Commission. So may I welcome Dr. Kwai, and I may also request the panelists now to come in front so that we can start our discussion. Dr. Kwai, karibu, and may I request you also to introduce the panelists who will be taking us through the discussion. Also, I understand that there are other partners who have joined us. I've seen a colleague from AMREF Africa. Maybe you just stand and raise up your hand. AMREF Health Africa. Okay. So maybe for those who have come late, also maybe you can grab a cup of tea outside, and you can come in as we proceed. So Dr. Kwai, karibu. So while we are setting up the presentations and inviting the panelists, maybe for those who maybe will need just 2 or 3 minutes, you can grab a cup of tea and come in. So may I welcome Professor Kaushik in front, Valeria, Dr. Nyasatu, and Norbert. May you please come in front?
Yeah, Dr. Nani. Wait, what a project. Dr. Mwenesano from NHIF. Yeah, please, may you come in front?
Presentation zote. Afanya king. Ni nani huko?
Okay, good morning once again. So we are going to start our symposium, and we are very excited to have you all today. So as you know, in Tanzania, NCD is a growing public health concern. And according to the WHO report, more than 33% of all premature death in the country is caused by NCD. And also, World Bank reported that diabetes prevalence increased from 3.2% to 5.7% in 2019. So Tanzania also has increasing burden of renal dysfunction due to many reasons, one of them being use of ART therapy for HIV positive clients. And you all agree with me that it's very expensive to treat non-communicable diseases. And it is approximated that about 30% of NHIF disbursement is used for the treatment of NCDs. Also in our hospitals, as our executive director said, we are coordinating a number of hospitals. We have noted that 90% of those patients who are accessing dialysis services are insured clients. So we have been asking ourselves, where do those who are uninsured go when they have renal problems? We really don't know. Maybe some of you might share the experiences in our discussion today. So today we are excited to have you all, our partners and other stakeholders, to discuss on this important symposium, non-communicable diseases and health financing. And CSSC also, due to this problem, has included NCD as part of our strategic priorities, and that's why today we are very honored to host you all. So we have our 5 panelists. We're very happy to have them with the skills and experience and knowledge, hoping to hear a lot from them. So I'll introduce our first speaker, Ms. Valeria Mlinga, who has just officially opened this. She's acting manager of NCD program for Ministry of Health. She has a background on nutrition and global health and development, and she has about 10 years experience working in the health sector. So we are very happy to have you, Valeria, today. Karibu sana for your presentation. So you'll have 10 minutes for your presentation, please. Time. Thank you.
Yes, thank you very much.
Thank you very much. So I have someone to help me with the slides, right? Okay, thank you very much. So I'm going to do a presentation on the National Strategic Plan on Prevention and Control of the Non-Communicable Diseases and the government priorities. Next, please. My presentation would have overview of the NCDs, risk factors. I think they would come and take a seat. Thank you. So we would see the global and national framework as well as the NCD strategy 2021-26. About 71% of all deaths worldwide are due to non-communicable diseases. That's from WHO 2016. And it's estimated that about 33% of all deaths are due to the non-communicable diseases. Next, please. Next. Thank you. Now, we have recently done our report on the district health information system, where we have data from 2017 to 2021, and it shows that about 2.5 million patients who were treated on NCDs compared to 3 million patients in 2021. And this shows the increase in the non-communicable disease by 9.4% from 2017 to 2021. And among all the non-communicable diseases that has caused many patients to attend the health facilities includes the high blood pressure, which was 688 to 1,345,000 in 2021. So we can see the burden is about ×2 from 2017 to 2021. And again, it's also shown in the diabetes the same from 2027 to 2021. We had about 336,000, and now we have 644,000. Next, please. According to steps, just to take you through on the indicators that we had, and one of the risk factors was the unhealthy diet, where we see the low consumption of the fruits and vegetables, and it was 2.8% of the individuals had only met the recommended daily intake of the fruits and vegetables, and 32%, you can imagine, among 100 people, only 32 consumed fruit and vegetables. And for the overweight, about 26% were overweight, while obesity was 2.5, and insufficient activity was 7.5, and the people with hypertension was 26, while diabetes was 9.1. And for the tobacco use, for the steps, we see it's 14%, but for the GATS, the Global Adult Tobacco Survey in 2018, it had reduced from 14 to 8%. And for the alcohol, it's about 29%. Next, please. So we have environmental risk factors, urbanization, poverty, low education, and stress. And all of this contributes to the non-communicable disease. But we also have the behavior risk factors that we all supposed to put effort into controlling them. But we also have the biological metabolic risk factors that we have not so much control. Next, please. Now, due to all the burden we see, due to all the expenses that the government puts, now the ministry has its priorities. Next. So among the priorities, I think maybe it's not very clear, but among the priorities, we have the leadership and governance, we have maternal and child mortality, but we also have the non-communicable diseases in the country, and this was also set even in 2022 national priorities. Next, please. Now, for the non-communicable diseases, as we already had a section since in 2009, and then later, due to increase in the burden and the government spends more money into the treatment of these diseases, the country decided to launch a program of the prevention and control of the non-communicable diseases. And this program was launched in 2019, and it was launched by the Prime Minister. And the program is shaped into controlling the major diseases such as the cardiovascular disease, diabetes, chronic obstructive pulmonary diseases, cancer, mental health illness, as well as the sickle cell diseases. Now, our program is being governed or is being guided by the strategic plan document on the NCDs. We had about 3 already, and now we have a third non-communicable strategic plan. Next, please. So apart from us having a strategic plan on NCDs, we also have, as a nation, we also have related policy frameworks that also align with the National Strategic Plan as well as the Health Sector Strategic Plan 5. So we have mental health strategy, National Tobacco Control Strategy, Health Promotion Strategy, we have National Cancer Control Strategy, Palliative Care Policy and Strategy, Breast Cancer Strategy, Cervical Cancer, Alcohol Policy, we have Food-Based Dietary Guidelines, Physical Activity and Sedentary Behavior Guidelines, and Alcohol Policy. And about 50% of these documents are very new, just launched last year. Next, please. So our National Strategic Plan 3 on prevention and control of the non-communicable diseases aims at reducing the death caused by NCDs by 15% by the time the document is end by 2026. And this death mainly includes the death of people from 30 to 69 years. Now, in ensuring the strategic objectives are met in the strategic, the Strategic Plan 3, the government is expected to use about 12.6 trillion in the next 5 years, which is about 2.3 trillion yearly, so as to reduce 15% of all the non-communicable diseases. Now, in our strategic plan, you might find that among the interventions, about 55.6% of the budget is allocated for buying the medicines and the equipment for treating the NCDs. Now we see if we do not allocate so much effort into this, the budget might even need to go higher, more than what we see now. Next, please. So our National Strategic Plan, it has a vision and mission. You know, it's always to have healthy and prosperous society free from NCDs. It also has principles, which includes primary health care approach, universal health coverage, where we're going to hear more about it, and then continuum of care, life course approach, multi-sector approach, and evidence-based. Next, please. We also have strategic areas. Next. Now I want to jump into strategic outcomes. We have about 4 strategic outcomes. One is leadership, governance, multi-sectoral collaboration, and accountability for prevention and control of the non-communicable diseases to have them strengthened. So this is what we have. We're even addressing the strategic outcome 1 for us all being here. The next one is the national capacity for NCD prevention. Now, let me just mention one thing before I go to the second one. For the strengthening of the leadership, we also had to bring forward the issue of non-communicable diseases to the parliament. So we had a committee of the parliament that was overseeing the HIV/AIDS, drug abuse, and tuberculosis. And now this committee, after the members of parliament realized the burden of the NCDs, they decided to let this committee to also oversee the non-communicable diseases. So this committee is a very important, and it brings forward the issue of the non-communicable diseases to the parliament. Now, coming to the strategic outcome number 2, we expect to have national capacity for NCD prevention and health promotion approaches targeting all modifiable risk factors. So here we talk about alcohol reduction. I'm happy we have people doing tobacco control, nutrition, sedentary life, and environmental, and other social determinants being strengthened. Coming to another strategic outcome number 3, this is the health system reorientation or strengthening to address the non-communicable diseases through promotion, preventive, and curative or rehabilitative services. Now, among this is one of a very important outcome, and for the moment for this year, we're working hand in hand with our partners, the TDA and many other partners, into doing trainings. And so far, the care and treatment for the non-communicable diseases was done mainly at the district health facilities. But due to designation of these services, they are now sent down to the health centers. Now, through that, we had to capacitate our healthcare providers. And Tanzania, Ministry of Health, in collaboration with TDA and other partners, we're expecting to train all the some healthcare providers providing the non-communicable diseases. From the health centers, about 600 health centers, and we expect to cover and reach about 2,600 health providers by 2023, next year, December. Maybe I go to the next one, strategic outcome number 4. This is the national capacity for the NCDs, surveillance, research for evidence-based planning, monitoring, and evaluation is being strengthened. So what we are doing here for the moment, we are working on our data, on our data platforms. Now we have the DHIS tool, which we could only see data from the district and from other facilities, but you couldn't find the data from the specialized facilities, or like the cancer registers were just standing on their own, or the data from Jakaya Kikwete Institute of Cardiac were just on their own. But for now, we are working into integrating all the data that are being collected in the country into one system, so that whenever you want to find the information about the health system, you would find them right away. But also for the strategic outcome of the surveillance, we are going to have a step survey this year. We're going to conduct the survey after the last 10 years, 2012. So we would have the step survey in 2022 after the census, somewhere after the August. Next, please. Next. So speaking of multi-sector collaboration, from the ward level all the way to the national level, having everybody on board. Next. This is the resource planning for the NCD. I already mentioned before, for us to implement, we need about 12 trillion. Next, please. Now, the model impact of our strategic plan, it's scaled up as invention to avert nearly 2,000 premature deaths as compared to the scenario which is current to what we have at the moment. And the probability of dying from NCDs will also be reduced, as I already mentioned before. But we also expect that the component of the NCD program are focused on to increase well-being and the mortality reduction, planned to achieve more than 400,000 of health lives if all interventions are being implemented. Thank you very much. I hope that is, next please, that is the, okay. This is about monitoring steps I mentioned and the data I already mentioned. Next please. Thank you very much. That's the end of my presentation.
Thank you so much, Ms. Valeria, for that presentation. I think it was good opening presentation. Without further ado, we'll go to our next presenter, Dr. David Raymond Mwenisano. He's from the National Health Insurance and will be presenting about universal insurance and financing on non-communicable diseases. Dr. David Mwenisano is the Director of Medical and Technical Services from NHIF. He's also a consultant physician. He has med in internal medicine from MUAS and Masters of Science from gastroenterology from MUAS as well. And he's also an external lecturer for Albert Kairuki Medical University. So karibu sana.
Thank you. Good morning. No, I think they are still working on my slides. Okay. Thank you very much, the organizers, for this meeting and for inviting NHIF to come and present on health financing for non-communicable diseases. I will go through, my slide will show you overview of NHI profile, literature review, but I'm going to skip because I know there are some gurus in the non-communicable diseases, diabetes and hypertension. So they will talk about literature. Financing sources, composition in Tanzania, and then you'll see NHIF experience in financing NCDs, measures adopted by NHIF to combat NSDs, measures adopted by NHIF to extend membership coverage, challenges, and way forward. NHIF was formed July 2021 by the Act of Parliament, chapter number 395. It was a result of health sector financing, health sector reforms, which took place during 1990s and came up with NHIF as an alternative sustainable healthcare financing option in Tanzania. And subsequent amendment of NHIF Act paved the way for extension of NHIF membership coverage, which eventually covered all employees in the public sector and other groups of members in the private sector. Objective was to create permanent and reliable system for the provision of health services to public and private sector, to improve accessibility and quality of health services, to reduce financing gap by supplementing the government allocation of funds, and to invest in economically viable projects in the health sector so as to improve and speed up its development. Other core functions of the fund is to register employers and employees, individual member groups, and their legal dependents, to collect monthly contribution from the registered employers and employees, to accredit healthcare facilities, to pay providers claims according to set NHIF claim procedures and the Ministry of Health treatment standard guidelines, to safeguarding members' funds and undertaking short-term investment as guided by Bank of Tanzania, to conduct actuarial evaluation in order to determine the viability of the scheme and its financial sustainability. It is government entity that operates under Ministry of Health. NHIF operates under the principle of risk sharing and solidarity among members. That is our number one principle, risk sharing and solidarity. NHIF started with 164,708 principal members in 2001, and most of them were public servants. But now, with the equivalent of beneficiaries, 691,773. But membership keep increasing. Now we have 1,284,122 members as of March 2022, translating to 4,639,000 beneficiaries, covering 8% of the total population. Tanzanian population is about between 58 to 60 million. We are going for census this year, then we will know exactly the population of Tanzania. I think by end of October, we will be knowing now how many are we in the country. So how do we do it? How do our members access medical services? All NHIF beneficiaries are identified at the point of service through NHIF membership ID and the NHIF online verification system. Access to medical services is through a wide network of certified healthcare facilities countrywide and some out of the country. But now we are in Burundi. We are covering some of our members there. Also, government different high commissions in different countries. And also we are planning to go to Congo and Rwanda. Access to medical services. By March 2022, position of certified healthcare facilities stood at almost 8,883, equivalent to almost more than 80% of the existing healthcare facilities in the country are working with NHIF. And actually, we have government health facilities, and then the faith-based health facilities and private ones. And the majority of faith-based health facilities which we have are under the CSCC, as it was already mentioned by the executive director. So you have majority of the, in the group of faith-based, CSCC has got majority of the facilities which are working with NHIF. As I've already said, I'll skip literature review because I know wako mabingwa hapa kwenye maeneo wanaweza kuzungumza vizuri. There's another slide which I want you to see. You can even skip that one. Yes, that one. If you look at the slide, financing sources composition in Tanzania, that yellowish or yellow color, from 2015-2016, you can see yellow one is donor funds. And then the gray one is out of pocket. So in 2015-2016, we had almost 41% of donor funded, 22% out of pocket, and is it pink or orange? The orange one, is health insurance. By then, 2015-2016, it was CHF and NHF were forming about 8%, and the blue one is government support. It was around 29. So you can see donor funds financing has been decreasing from 41 to, it reached 27% in 2018-2019. But 2019-2020 it went up to 33%. Out of pocket it kept increasing from 33%, from 22% to 32%. But there is a very minimal increase in terms of health insurance. Why? Because in Tanzania, insurance is still voluntary, except for public servants who are joining the fund under statutory. But the rest are involuntary, and you cannot achieve much when you continue with involuntary way of recruiting members. That's why NHIF is pushing for, together with the Ministry of Health, we are pushing for mandatory health insurance. So that we can reduce that gap of out of pocket from 32% probably maybe to 0. Everyone knows how health care costs due to NCDs. It drains households' income and it forces millions of people into poverty. Burden of NCDs to individuals and households, which may deprive equity to healthcare services, call for extension of health insurance coverage to large part of the population. NHIF benefit package covers or treat both infectious and non-communicable diseases, and it covers all identified major non-communicable diseases, including cardiovascular diseases, cancer, respiratory diseases, diabetes, and treatment associated with renal failure. The slide which, next, I'm faster than the coordinator. That slide is showing benefit payment to cases related to 4 non-communicable diseases. From 2017, 2018 to 2020, 2021, amount in billions. Anti-cancer, from 2017, 2018, it was around 19.2 billions. But you can see, by the time tunafunga mwaka, by the time we end the year 2020, 2021, it has gone up to 27.8. So you can see it keeps increasing, increasing, increasing. So we need to come together and see the cancer goes down and the cost also goes down. Chronic renal failure and related services, including dialysis. The fund paid in 2017-2018, 22.8 billion. But you can see, by the time we are closing the year, 2020-2021, government financing, it was around 46.5 billion, almost double of what we have paid 4 years ago. We doubled from 22.8 to 46.5, more than a double. Cardiac services, including antihypertensive medicines, it also doubled from 14.7 to 28.4 billion. Diabetes, also the same. So you can see, in just a space of 4 years, the amount has been doubled. So this shows that there is evidence of increasing of non-communicable diseases in the country. So in 4 years period between 2017-2018 and 2020-2021, 4 selected non-communicable diseases utilized almost 19% of total benefit. Total benefit payment. Next. Next. %17% of the total benefit payment was paid to 4 selected in 2017-2018, which increased to 21% in 2020-2021. Among 4 selected non-communicable diseases, that is chronic renal failure was leading in terms of utilization, almost billion, Tanzanian shillings 134 billion, followed by cancer services, which costed Tanzanian shillings 94.6 billion. For the selected list of non-communicable diseases, average cost of treatment per patient per annum, it ranges between 12.5 to 69.9 million. Kwa mwaka tunalipa milioni 12.5, milioni 12.5 kwa mgonjwa mmoja. Hiyo ni kwa invasive cardiac services, and for cancer treatment 69 per year. So you can see the need for all Tanzanians to come together under the risk sharing and solidarity principles of health assurances, so that we can support each other. Individually, no one can afford to pay 12.5 million or 69.9 million for cancer treatment. NHIF endeavors to make sure that health insurance coverage is extended by developing products which are specific and affordable by particular population group. Next. I just pick, you can just look at the red colors there. Dialysis alone, if you look at the dialysis, 2017-2018, NHIF paid around 17.3 billions, but it kept increasing. 2018-2019, 23 billion. 2019-2020, 29 billion. 2020-2021, 32 billions. That is dialysis only. Anti-cancer also the same. From 2017-2018, 15 to 26.2 billion in 2020-2021 in cardiac services. So we have measures to adopt by NHIF to combat non-communicable diseases. Next. Amounting public awareness in collaboration with other stakeholders in health sectors. That is change of lifestyle and exercise. Health checkup for supplementary customers. We have corporate customers. They have health checkup. NHIF provides health checkup for customers who paid for health checkup through supplementary services. Through this, NCDs can be detected at early stages. Health checkup and awareness campaign to the public during exhibitions. And this slide shows measures adopted by NHIF to extend health insurance coverage. Number one is Total Afya Card product to cover those who are under 5. And we have also student card or student scheme for higher learning institutions. We have Ushirika Afya for farmers and cooperative unions. Umoja Afya product for boda, cyclists, drivers, associations, machingas, etc., etc. And the health insurance bundles, popularly known as Vifurushi. All these are the efforts which NHIF came up with so that to make sure the large population of Tanzania is covered. We also have a strategic partnership with commercial banks to provide soft loans to prospective members, especially those who are joining together in groups. Opening window for premium payment by installment, common known as Dondoliza. If you have a scheme of maybe which costs 908,000 per year, then you can keep contributing slowly, little amount till you reach 980, then you get your card, instead of paying the whole amount at once, which is difficult for some people to do. Providing health insurance covers to retirees. Now, retirees who are under government or who joined under a public scheme, they have health insurance cover even after their retirement, but we are working also with the private sector to make sure they are also included. And somebody was asking me, what about those who retired from farming? Because also informal sector can retire. You've been in farming and then you retire. What is your plan as a fund? Or maybe as a country? So we have some challenges. Number one, increase in non-communicable diseases. This is a big challenge, by the way. Number two, voluntary membership. As I've already said, without mandatory health insurance, and if we continue with voluntary membership, then this one we cannot reach anywhere. As you have seen, since 2001, up to now, almost, you're talking about 20 years, only we have managed to cover 14% in all insurances, but NHIF has 8% shares. Prudent practice, limited coverage of services within East Africa, and increased medical cost. Way forward, enforcement of the law as I've already said, health insurance to be mandatory to all citizens, investing more in ICT in order to curb fraud practices and improving operational efficiency, institutionalization of social health insurance within East Africa state, and strengthening health promotions program to enable NHIF beneficiaries in Tanzania and at large to prevent them from diseases, especially NCDs. To conclude, all players in health sector, including NHIF, to continue advocating health lifestyle among people, especially to those with limited physical activities. Employers should continue to allow and support sports bonanza among employees. Encouraging medical checkup for risky groups, especially to corporate customers. Thank you for listening.
Thank you so much. We're getting a lot of things, I hope, that will enable our discussion. So our next presenter is Professor Kaushik Ramaria, who will be presenting on cost of NCDs. Professor Kaushik is currently the member of board of World Diabetic Association, and also Honorable General Secretary of Tanzania Diabetic Association in Tanzania, and also Tanzania NCD Alliance, and Honorable General Secretary Association of Private Health Sector Facilities in Tanzania. So Professor Kaushik Ramaria served as a chairperson of Sub-Saharan Africa region of International Diabetic Federation from 2000 to 2006, and also then as the vice president of Global IDF from 2007 to 2012. And during his tenure as a vice president, he also facilitated the development of several tools on NCDs in major 3 languages, English, French, and Portuguese. The tools included diabetic declarations for Sub-Saharan African region, clinical practice guidelines for type 2 diabetes, and diabetes education manual for diabetes educators in the region. So we are very pleased to have Professor Kaushik today sharing his experience on non-communicable diseases, especially diabetes, but also since he's practicing in a private sector, he will also tell us about the costs of treating NCDs, as we have already had some from the previous presenter. So karibu sana, Professor.
Thank you very much for that introduction, and thank you for the invitation. I've basically divided my presentation into 3 different components. One is burden, and then the second one is looking at the different economic costs, and then looking at the cost of NCDs in Tanzania based on the reviewed literature. So can I have the next slide, please? So if you see the non-communicable disease, every second, 28 people between age of 30 and 70 are cut short. And these are the deaths which occur, out of which, of those 28 people who die, 25 are from the low and middle income countries. And it's basically, this is death which occurs due to the non-communicable disease, due to the failure of the policies, programs, and the health system. Next slide, please. So what are the leading causes of death globally for the non-communicable disease? So if you see 74% totally deaths which occur globally are related to the non-communicable disease. And the commonest top 3 are basically ischemic heart disease, stroke, and chronic obstructive lung disease. Next slide. So what's NCDs in Africa? When you talk about African region, I think we have very few community-based studies. Some countries, especially Republic of South Africa, is overrepresented in most of the data which is available. The prevalence of NCDs and risk factors varies considerably between countries, urban and rural settings, and other subpopulation. And the prevalence of NCDs and the risk factors is high in some of the sub-Saharan African countries. Next slide. So based on the declaration which we had from the WHO, If you look at the WHO, it was basically initially 4x4, which maintained that there were 4 risk factors and 4 diseases, which are cardiovascular disease, diabetes, chronic respiratory disease, and cancer. Subsequently, mental disorders, violence and injuries, hemoglobinopathies, oral disease, eye disease, and renal disease have been added onto that component based on the idea of WHO Afro declaration, which was there in Brazzaville. Next slide. So if you look at the burden of NCDs in Afro region, next slide, just go on, press, yeah. You will find that within the African region, you will find that the burden of NCD is going to increase from 40% in 2010 to 55% in 2025. So the majority of the deaths which will occur in the African region from 2025 is estimated to be more than 55%. Next slide. So this is from the NCDI poverty report for Tanzania, and if you look at the burden of disease, and if you look at this blue line here, NCDs, if you see from age 1 to 4 and age group, you can see that actually the NCDs, as you go from 40, 45 years of age, you find that the NCDs and the injuries actually are increasing dramatically. And this is the report which was just published in 2017, looking at the burden of disease for Tanzanians. Next slide. Again, if you divide this NCDI and look at the disease category within the Tanzanian sector, then you find that it's not only diabetes, chronic respiratory disease, cancer, and cardiovascular disease, but you've got all other non-communicable disease, what we call as NCDIs, which also contribute very significantly. And if you break down the NCDs, just concentrating on these 4, the other things which you find is mainly the complications which you get, but at the same time, there are other disorders which we are not actually picking them up. Next slide. So what happens if an individual has hypertension? So in a Tanzanian setting, if a person has hypertension, then 53% of them basically have cardiovascular disease, 18% are previously diagnosed but not on treatment, 3% of them previously diagnosed on treatment and well controlled, 5% previously diagnosed but not controlled, and 21% newly diagnosed ever measured. So you find that out of 100 people with hypertension, only 3 are well controlled, while 97% are not well controlled. And of those 97%, probably more than half of them don't even know that they have hypertension till they go to a clinic. Next slide. The same is with diabetes. If you find that if you have 100 people with diabetes, 50 know that they have diabetes. Of those 50 who know diabetes, only 50% are measured and only around 7% are well controlled. Next slide. This is again a scenario which shows what is the evolution which is taking place. So if you look at gestational diabetes, you find that in 1990, when it was published initially, GDM was 0. And then after 10, 20 years, you find it's around 8.4%. And the recent data show around 19%. And recently there's a study from Korogwe which is showing GDM of 24%. So you find that again there's an evolution which is taking place with the lifestyle change, weight, and basically the nutrition and the lifestyle factors. Next slide. What is important for us is to know that it is not only the NCDs, but when it is NCD, it is the multimorbidity which is causing a problem. And this is data from South Africa which shows that if you go into a clinic with hypertension, you find 75% of them have diabetes, around 27% have HIV, and around 4% of them have basically TB. If you go into an HIV clinic, 27% of them basically have hypertension, you find 24% have TB and 17% have diabetes. And in that diabetes clinic, 97% of them have hypertension, 8% have HIV, and around 2% have TB. And in a TB clinic, again, you have HIV, which is 80%, hypertension 37%, and diabetes 12%. So what you are seeing is that when you have a clinic which is for diabetes, it is actually picking up all the other complications. And if you are not aware of it, you find that you will lose out on other diagnoses. So overall, multimorbidity prevalence is around 22.6%, and 94% had 2 conditions, and more than 5% had 3 conditions. Next slide. This is a projection of a clinic from Zimbabwe, and again what you see is that the projection is that in HIV positive population and HIV negative population, you see that in HIV positive population, you will find that more and more people NCDs. And this is a component where we are talking about integrated clinic approach, that in a chronic disease clinic, because HIV is now a chronic disease, you need to make sure that you are actually managing the NCDs within, within this HIV. Next slide. Next slide, please. Now, what are the economic costs? Next slide. So if you see the financial risk protection, the incidence of catastrophic healthcare payments in Africa is extremely high, and it is progressively increasing. About 97 million people in the African region, representing 8.2% of the continent's population, incur catastrophic healthcare costs at the 10% threshold annually. The proportion of these individuals are pushed into poverty is also very high, and it is reducing 15 million people, representing 1.4% of the continent's population, are pushed into poverty annually because of the out-of-pocket health expenditure. So every year you find 15 to 20 million people in the region get into the level of below poverty line because of the NCDs. Next slide. So this is basically a graph showing the catastrophic spending, health expenditure from WHO in 2019 from the UHC report. And if you see, Tanzania is somewhere here. So you got around 3.8% proportion of the population who has got a catastrophic health expenditure which occurs in these countries. Next slide. This is a slide from IDF Global. And what it is showing that overall, if you see in the US dollar from 2006, with an increasing burden of diabetes and its complication, you can see that overall cost of diabetes is so going up all over globally. Next slide. And if you look at diabetes-related health expenditures, you find that in high-income countries, the expenditure is around 600 billion USD, while if you see low-middle income countries, you find that the expenditure is also increasing, but at the same time, the amount of funds which you are allocating to the expenditure is quite low. Next slide. This is the percentage of the GDP which is being spent in the diabetes care, and if you find in the African region, about 0.7% of the GDP goes into management of diabetes care, and this is also not optimized management. Next slide. So comparing the out-of-pocket expenditure in developed versus developing nations in sub-Saharan Africa, data from 2014, you find that developing nations, the out-of-pocket expenditure in Sierra Leone was 76%, Nigeria was 66%, Mali 61%, Niger 53%, and Uganda 49%. So you find that overall it's a completely out-of-pocket expenditure is more than 50% in most of the countries in the African region. Next slide. So this is the economic burden of diabetes, whereby you say it's a direct cost and indirect cost. And if you look at East Africa, you find that overall cost, economic burden is around 39.7%, and it accumulates to around 3.8 billion per year. Next slide. Next slide, please. So what is the affordability of the drugs? And this is, again, looking at sub-Saharan Africa's 4 major countries in the sub-Saharan Africa. And if you see, if somebody has to buy metformin in Tanzania, it actually amounts to around 5 days. This is the data from 2017. It amounts to around 5 days of a month's wage for a minimal paid worker. And for glibenclamide, it is around 1.5 days of wages. Next slide. So from the World Health Statistics Report of 2018, diabetes worsens the poverty. The treatment cost exceeds 25% of the household income. Women have to leave work to be caregivers. Children leave school to care or supplement household incomes. And money which is spent on tobacco is money not spent on any other needs, because you basically are, with use of money on the tobacco, you are increasing your risk factors on non-communicable disease. Next slide. So in 2009, the total health expenditure for Tanzania was only 37 USD per capita compared to 7,960 for USA and 3,440 for UK. So the first study looking at the diabetes cost in Tanzania came from Dr. Stella Chale, and this was in 1991. It showed that it would require 9% of the total health budget for the government to provide medicines and one test strip a week to care for people with diabetes. This was in 1991. Next slide. In 2011, we looked at a multi-country study looking at the cardiovascular disease and economic cost of the strokes. And if you see, 1/3 of the respondents did not take their medications as prescribed, and 76% could not afford the medications. There was a decrease in self-related health after a CVD event was observed, and 95.4% of the participants was, there was a decrease in self-related health after a CVD, and more than 95% of them basically had an effect which was could not buy the medication. So as a result, both individual income and household income showed a decline across all the socioeconomic groups. Next slide. So if you see, it was comparison between Tanzania, India, China, and Argentina. And if you see that the catastrophic spending was much more in low middle income groups than in the middle and the high income groups. And distress financing was also very high. And this was basically in patients who had stroke, whereby their families had to sell their property. Next slide. We also looked at the microeconomic impact of diabetes in Tanzania. So you find that 69.8% of the respondents experienced catastrophic expenditure related to the illness. The absolute high costs were paid by the highest income groups, while relatively total expenditure was biggest burden on the low income groups. And 94% of the finance came from out-of-pocket expenditure. Next slide. So if you see that in a people, it was a case and a controlled study, and if you look at people with diabetes, which was in red, and age and sex match controls who did not have diabetes, you find that people with diabetes had blood pressure 3 times more common, stroke was 3 times more common, other heart disease was 2 times more common, heart failure was 3 times more common, and heart attacks were 3 times more common than people who did not have diabetes. Next slide. And how were they using the hospital services? And this is where NHIF comes in, because you find that in people who had diabetes, their medication visit is 7 times more common than those who do not have diabetes. Outpatient visit is 9 times more common than who don't have diabetes. Their casualty ward admission is 5 times more common, overnight admission is 5 times more common, and overall, they use the hospital services 4 times more. And the reason is because if their blood sugar is not well controlled, they tend to come back again and again to the hospital with the complications. Next slide. So this was calculation done by Professor Swai some times ago, about 3 years ago, and this was projections based on the NHIF, and actually Dr. Mensano today confirmed our estimates, because what you find that if you were to put all the patients with diabetes and hypertension into the NHIF system, then you will have that 20% of overall budget of NHIF would go into management of basic treatment for diabetes and hypertension. Here, again, if you look at the overall health budget of the Ministry of Health, it would cover around 6 to 7% of the overall costs. Next slide. This was a study which we did about 2 years ago, looking at different components of oral medications, asthma drugs, and looking at the insulin supply. And again, you can see that the burden of basically buying the medications and the cost of medications is extremely high. Next slide. Next slide, please. So this is with children with type 1 diabetes, and what we say is that if you are able to control your blood pressure well, and if you are able to control your blood glucose well, and avoid the complications, then down the stream, you are able to actually reduce your expenditures. And you find here that in people, in children with type 1 diabetes, whose HbA1c is very poorly controlled, you find that they have much more complications than children who have got a very good control of the glycosylated hemoglobin. Next slide. So if you do intensive control, at the end of 30 years, you find that basically there's a net gain in the overall cost you spend out of this patient, rather than in a poorly controlled patient. So if you look at the Tanzanian data, you find that if you intensively control your type 1 diabetes, your cost would come to around $21,000. But if you are going to have somebody with a poorly controlled type 1 diabetes, you're going to spend around $51,000 per year. Next slide. This is again from NCDI report, and it shows expenditure on non-communicable disease. And you find from 2014 to 2016 the data, you find that the per capita expenditure is going up, and you find even the USD spending is also up. It's not capture all 100% of the expenditure which is there, but whatever is there, you can see that there's an increase in trend. Next slide. This is a study from Felician, who did his PhD into NCDs and economic effects. So accordingly, the general sickness in Tanzanian setting diminishes the household income by around 7.6%. Overall, NCDs deplete income by 53%, and the households that are affected with NCDs are anticipated to fall under catastrophic expenditure by 31.5% compared to households which are affected by communicable disease. And the odds of households impoverished are 68% higher to households with NCDs compared to other households that support from the general illness. So you find that overall, if a family has an NCD person with NCD within a family, the catastrophic costs are anywhere from 31 to 68%. Next slide. This is a study looking at economic burden of cardiovascular disease and hypertension in low and middle income countries. It was a systemic review from the African region. And what it says was that average monthly cost for hypertension treatment is around $22. Average monthly treatment cost for stroke and coronary heart disease range between $300 to $1,000. The variability across the estimate was extremely high. And in most of the low and middle income countries, the annual cost of care and the cost of an acute episode exceeded many times the total health expenditure per capita. Next slide. So this was a study which was done from Muhimbili, from the emergency department. Cost of treating hypertension in Tanzania, recently published in 2021, and you find that the estimated unit cost for treating hypertension was 165,465 shillings, where the main cost driver was length of stay in the hospital, which drove the provider's cost. Sensitivity analysis showed that the cost of health personnel is the driver of unit cost for hypertension treatment in a setting in Tanzania in the zonal hospital. The high cost was due to high waiting times patients spent while seeking treatment, and the reduction of the average length of stay by 50% resulted in 50% reduction in the unit cost of treating hypertension. So overall, the cost of treating one hypertensive patient per year at the department in Muhimbili is estimated to be about $272,831 per patient per year. Next slide. So if you were to initiate a primary prevention of the cardiovascular disease, and what is the net cost saving? Again, study from Tanzania looking at the economic cost of primary prevention, and you find that the evidence-based preventive measures are crucial to limiting the increasing burden. And if you were to basically have primary prevention of cardiovascular disease as currently delivered, it would cost you around 30 to 71 per patient per year, depending on whether you are in a rural or an urban area. So the cost of prevention would be much, much cheaper than the cost of treating this person. Next slide. Again, looking at the dialysis costs, again, this is a review from the other countries in the African region. You find annual cost per patient varies from around $11,000 to $36,000 in Nigeria to $24,000 in South Africa. But if you look at the dialysis costs in the Tanzanian setting, which has just been put in, that is around $176, which comes to an average cost of dialysis within the African Tanzanian setting. Next slide. What are the out-of-pocket cost of asthma follow-up care in adults in sub-Saharan African country? Again, mean annual direct cost of asthma care is around $368 per patient. and the medication cost accounted for around 87% of this cost. And the direct cost was mainly visiting the emergency services, hospital admissions, medications, outpatients, and other investigations which were done. So if you are able to manage asthma very well, then you are able to reduce this direct cost and overall reduce the total cost there. Next slide. Financial burden of cancer, a big question mark because we do not know exactly what are the costs of the cancer. What you find from NHIF data is the number of patients who have been managed, but again, unit cost. And based on the estimates from the ministry, 95% of the cancer patients in the country die at home with the terminal care and terminal cancer, and only 5% are coming into the hospitals. So due to the lack of the big data on cancer and absence of an overall unified cancer registry, correct estimates of impact of this disease in the Tanzanian economy will not be known. Next slide. So health financing, again, this was shown by Dr. Menisano, but if you see over 2002 to 2011, 2012, you find that the public sector spending from 25%, 28, 26, 22%, development partners 42 to 48%, household out-of-pocket is anywhere from around 27 to 25%, and other private is around 4 to 5%. So basically the cost factors and out-of-pocket is still very high. Next slide. This is again how much is going to be spent on health now and in the future. And currently in 2017, from the current data, you have basically the $18 is going to be the development assistance, $15 is the government health spending, $10 is a out-of-pocket spending, and around zero here was just a small number here. You find that you have got prepaid spending here. While if you find in 2015, it is estimated that development assistance will be $14, government health spending will be $47, out-of-pocket will be $20, and $1 will be basically private insurance where they'll be looking at those things. Next slide. So what are the challenges? I think the major challenges are that there is a chronic underinvestment within a non-communicable disease, and you can see from this graph that maternal child health, HIV, and malaria programs, you have got huge amount of funding, but if you look at where there's an increasing burden, the amount of funding is very minimal. Next slide. And again, if you look at 2019 figures, you find overall assistance in NCDs was only 0.7 billion, while in HIV/AIDS, the assistance was around 9.5 billion. When you look at the burden of the disease, it is the other way around. Next slide. And this is overall government spending as per the Abuja Declaration. How many governments are attaining the Abuja Declaration, and you find only about 6 to 8 countries are achieving what Abuja Declaration was, that 15% of the budget should be allocated to health. So we are far from reaching the Abuja Declaration. Next slide. So what is the way forward? Next slide. The way forward is the WHO best buys. And if you look at the best buys, which has been just released, you can find that for an additional $0.84 per person per year, 7 million lives could be saved and over 230 billion economic benefits could be gained. Tackling NCDs is highly cost-effective investment, and the calculated return by 2030 for each dollar spent, you will have a return of $7. Next slide. So it covers the 16 NCD best buys, main 6 intervention areas in tobacco, alcohol, healthy diet, physical activity, management of cardiovascular disease, diabetes, and cervical cancer. And again, based on the estimates from the low and middle income countries. Next slide. You find that if you just invest in $1 in tobacco, your return on investment is $7. If you invest $1 in alcohol prevention, your return is $8. If you invest in healthy diet by $1, your return is $11. You find physical activity investment of $1 will give you $3 return. Cardiovascular, $1 investment will give you $3 return. And HPV vaccination, $1 will give you $2 intervention. So if you find that if you just go to these 3 ones, the tobacco, alcohol, healthy diet, you are having a huge return through investments of what you do in prevention. Next slide. Next slide, please. So what is the key message? Investing to tackle NCDs will lead to healthier, more economically productive people and substantial improvement in the national output. There is a need to accelerate investment and implementation of NCD interventions to meet the SDGs and the global targets. And the recovery from COVID-19 gives the world an opportunity to build back, better improve health security, protect the health of those who need it, and addressing NCD should be the integral part of this response. Next slide. So where we should be spending the money? Currently, from NHIF data, we are spending money at tertiary and secondary care, nothing at primary care. We should be spending more at primary care and less at the secondary and tertiary care. Thank you very much. Yeah.
Thank you. That was very interesting. Thank you, Professor Kaushik. Now I'm going to invite our fourth speaker, Dr. Norbert. Is going to share his experience from Hamburg, health insurance and non-communicable diseases treatment. Dr. Norbert is also an internal medicine specialist and also cardiology in Hamburg, and the chairman of Professional Association of Environmental Physicians and Association for International Medical Cooperation. He's also a member of German Society of Internal Medicine. So he's going to share his experience from Germany. Looking forward. Thank you.
Asante sana. So thank you for inviting me to give a short speech here, and it's a great honor for me. And I will give you the point of view of Germany, where we are today and where what we can do in prevention and what is the effect of prevention, and also how we finance that. It's only a short overview. So non-communicable diseases, what are we talking about? I think that has been done, and I will go over that. Historically, non-communicable diseases have been the diseases of the rich, but this changes rapidly now, as we have seen. In NCDs in Germany, what are at the moment, or a few years ago, as this statistic came, what are the costs? On the right side, you see on top the cardiovascular diseases, then digestive diseases, and then psychiatric and behavior diseases. In the lower right, musculoskeletal diseases, cancer, and then endocrine diseases. These, the 5 NCDs, and with the endocrine, the 6 will cause 50% of the costs of our health insurance system. The total costs of health insurance systems a year is 236 billion euro. And 40% are caused by these 6 diseases. So why is it like this and so different to Tanzania? I think, and the next question is, will Tanzania face the same situation within the next decade? The key difference between Germany and Tanzania, from my point of view, is age distribution. Here you see the age distribution of the German population, and you see that about 50% of the population is older than 50 years. Here you see the Tanzanian population, and only a small part of the population is older than 50 years. So that corresponds with the life expectancy for Germans of 80 years and for Tanzanians of 60 years. So the role of age for the different NCDs. On the left side you see diabetes. It's inverse, but I didn't find another picture. And so if you see diabetes starts with about 40 to 50 years age, and then up to 70 to the 70s, we have a percentage of 35% of the population that has diabetes. On the right side, you see the same thing for cardiovascular diseases. The younger population is not affected, has no problems or only small, and the population over 50, 60 years, it starts to get a problem. Other examples, on the left side you see musculoskeletal diseases, and also here you see that the increase is starting with 50 years about. The right side you see the prevalence of hypertension, and also this is low with younger people and starts to increase rapidly with 40 to 50 years. Conclusion. The higher the life expectancy, and thus the average age of the population, the more frequently NCDs dominate the disease process in a country. If the average life expectancy in Tanzania continues to increase in the coming years, now around 60 years, the importance of NCDs will also inevitably increase. Other facts that make the numbers of NCDs grow: overweight, we heard it before, overweight, lack of exercise favors diabetes, atherosclerosis, musculoskeletal diseases. Smoking, excessive alcohol, junk food, high in sugar, salt and saccharide fats promotes most important NCDs. Diabetes not detected and not treated leads to atherosclerosis, coronary heart disease, stroke, blindness, renal insufficiency and amputation. This is what my colleague just said. These diseases come together. They don't come alone. Diabetes comes with hypertension. Hypertension leads to stroke and renal insufficiency and so on. Arterial hypertension not detected and treated leads to heart attack, stroke, renal insufficiency, dementia, amputation, and many types of cancer can be cured if they are detected earlier nowadays. For example, colon carcinoma, colon carcinoma and skin cancers. But many of them are again correlated with age. So you see the obesity, which is a main factor for diabetes, increases in Germany with the age of the patients. The physical activity with age decreases, and so also this is age dependent. So what can be done and has to be done to fight NCDs today? I assume that nobody wants that the life expectancy in Tanzania remains at 60 years. And so I think the aging process of the population is set. Avoid handling it like we did it in Germany in the 60s and 70s. Yes, it's the same. Wait until people get seriously ill and then intervene. This will not work. It would be most painful way for the people, most cost and most expensive way for the health system, the economy, and the people itself, leads to poverty. Better ways: start prevention of the most harmful NCDs now: diabetes, high blood pressure, arteriosclerosis, and cancer. And another point, I think it's important, win the companies for this process. To install their own prevention programs, because it's in their interest to have healthy employees who work in the companies for a long time. This is a point we have in Germany, and the companies got it, that it is their interest to invest in health of their employees. Prevention plans of the statutory health insurance in Germany today, what we are doing for prevention. So from the age of 34 years, once and every 3 years, you got a health check that is included for the with the statutory health insurance. And this includes blood detection, blood pressure, and search for kidney diseases, and so on. From the age of 35, patients are entitled to a free skin cancer screening every 2 years. Women from the age of 55 and men from the age of 50 are entitled to a colonoscopy for the early detection of bowel cancer. And then there are prevention plans especially for women, starting with the age of 20 years, yearly examination of cervix, smear test, and cervix and neck of the womb, and examination of the extracted cells and the palpation. Starting with the age of 30, they got annual examination for the early detection of breast cancer by palpation made by the doctors. From the age of 50 to 69, you got an early detection of breast cancer, and that consists of mammography screening every 2 years. It's also included with the insurance. For men aged 65 and over, an aneurysm screening by sonography to detect an abdominal aortic aneurysma at an early stage. Men aged 45 and over should have their prostate examined once a year, but we don't do PSA testing because that has been a long discussion, and it is more harmful than useful. Harmful because of the treatment that is done with a positive PSA test alone. And so there is no more PSA testing in our country as a prevention program. So just to show you what can be done by prevention, you see this is from 1990 to 2003 statistics, and you see the CHD mortality in Europe decreasing despite an ever aging, more aging popularity. And so this is the only it makes sense if this is the effect of prevention programs. So nobody is perfect, and here you see the use of prevention services against cancer in Germany. It's data from 2004 I found, and it is in the younger population. The women are better than the men, but in the younger population they don't go to the prevention. But in the elder population it starts, and there the men are better. I don't know why, but it is. So what does prevention cost in Germany? It's very difficult to figure it out because there are different sectors: the health system, the medical systems, laboratory, nutritional counseling, promotion of sports, health education. I didn't find exact figures. So, but what is estimated is that the prevention costs about 5 to 7% of the total budget. And this is not too much. But it's the same, I think, the same as you found here with a cost effectiveness of $1. So who pays for all this in Germany? We have, it's a roughly picture, but you have two systems. You have the statutory health insurance. If you work, you are obliged to pay about 7 or 7.5% of your gross income to the health insurance. The employee has to pay another 7 to 8% of the health of your gross income. And there is a limit. If your gross income is more than 60,000 euro a year, you are free. So you can quit the statutory health insurance system and be insured by a private insurance, or not insure yourself. But if you are under this limit, you are forced, it is mandatory for you to be in the statutory health insurance. Family members without income are included. And pensioners pay the same 7 to 8% of their pension, and the pension company pays another 7%. If you live from social welfare, the health insurance is paid by the authorities. Private insurance, you normally pay according to your risk. That is why young people pay less than older ones. Nowadays, the insurance companies have to build a stock for elder people with the aim that the contributions don't rise so much with age. For example, I pay 750 euro a month for my health insurance, as well as my wife does. That's a lot, but we cannot change it. My summaries for you on NCDs: prevention will be the key to manage this. Know your numbers. I found this slogan here, and I think it's a very good slogan. Know your numbers and early and consequent treatments. Start now, not when the wage is even higher. It is the least painful way for the patients, and on the whole, it's the cheapest way for the health system and economy. Thank you very much. Asante sana.
Thank you. Thank you so much, Dr. Norbert. So now we are going to have our last speaker, Dr. Nyasatu Chamba. She's a specialist in internal medicine at Kilimanjaro Christian Medical Center, KCMC, and a lecturer at Kilimanjaro Christian Medical University College in Moshi, Tanzania. She's been active working in inpatient and outpatient departments. And also, Dr. Nyasatu is currently a PhD candidate within Adaptive Disease Control Expert Program in Tanzania, where she's leading a work page one, which is based on the integration of tuberculosis and diabetes military services in Tanzania. So this research will focus on creating a model which will address early and accurate bidirectional screening of TB and diabetes in client-friendly manner within Tanzanian healthcare system as an attempt of halting the dual TB diabetes mellitus epidemic. Karibu, Dr. Nyasatu.
Thank you for that introduction. Good afternoon, everybody, or good morning still. Good morning, yes. I'll take you through the experience that we have during our clinical workup and also through our teaching services that we have within Kilimanjaro University. So this will be my outline of presentation, where we'll cover the burden or the scope of NCDs within the Northern Zone, and mostly within Kilimanjaro Christian Medical Hospital. And it will cover through diabetes mellitus, chronic kidney diseases, neurological diseases such as strokes, together with cardiovascular diseases. Coming to the burden of NCDs within Kilimanjaro region, one of the study that was done, it was a community-based study. And we found that 31% had hypertension, 28.7, approximately 29 were obese, and 11.9 had CKD together with glucose impairment, which accounted to 26.8%. So here we see that 17.5 had pre-diabetes that were diagnosed, and 9.4% were already diagnosed to have diabetes mellitus. Next slide. And complications were also observed within our community-based study that was conducted in northern part of Tanzania, Kilimanjaro region. We found that 21.7% had glucose impaired, which concluded to 5.7% with diabetes. And awareness among these individuals was very low, to about 35.6%, whereby the diabetes complications were 50.2%, and renal complication among these diabetes individuals accounted to 12%. Ophthalmic complications were approximately 50%. Neurological complications were 29%, and other abnormalities were also observed among these individuals. Coming to the chronic kidney diseases, a study that was done also in Moshi region found that the prevalence of CKD accounted to 70% within the region, and associated factors among these were hypertension, diabetes mellitus as well, together with HIV/AIDS. Hypertension, as one of the other NCD, within a study that was done, it was also a community-based study, we found that 28%, that was the prevalence, and above 60 years accounted to approximately 59% of the individuals. Between 40 and 59 years, we found that 30.19% also had hypertension. And the prevalence of hypertension in individuals less than 40% was 11.6%. And other contributing factors was an increased BMI as well that was observed in 27.4%. And the mean systolic blood pressure was 129.5, diastolic being 77. So we see the burden of hypertension across these age groups. And we see that hypertension is mostly being experienced in age groups of even less than 40 years. Now coming to KSMC itself, which is a Christian-based hospital known as Kilimanjaro Christian Medical Center. It was opened in 1971 under the Good Samaritan Foundation. Officially, it has 630 beds with approximately 1,000 outpatients in a day. And we see that different studies were done, and KSMC was among of them, and NCDs contributed to 79.9% with a long list of the non-NCDs that were also observed within the study. Next, please. Recently, a study was done about readmission individuals who had heart failure complications, and we found that within the medical department, 14.4 individuals had heart failure. Approximately the high burden was among females with 65.2%, with the classifications of this heart failure being the highest stage 4 of 42.2%. 60 of them had hypertension, and 23.8 of them, approximately 24, had diabetes mellitus. And we see that the readmission rate of heart failure individuals within the hospital was 39%. Coming to the vascular diseases within the center, we see that the leading cause is stroke, accounting to 8.4%. And going down the list, following uncontrolled hypertension, we have hyperglycemia, where individuals come with complications. We have renal failures together with acute coronary syndrome. So from the graph there, we see that this burden of vascular diseases has been increasing over the years to approximately annual admissions of stroke accounting to 200 individuals. This is also the burden of heart diseases within the center, and hypertension together with diabetes mellitus being the most common presentation within the hospitals, with the other complication from the list. Next. And from the referrals that we get into the KSMC hospital, we see cardiology or cardiovascular complications have the highest percent, accounting to 52% of all the referrals that we receive within the center. So as we heard earlier from the Ministry of Health, that quality of care, usually we depend on the standard treatment guidelines. And these standard treatment guidelines are our essential guidelines together with the essential medications that are available to our individuals so as to better improve these services, as well as the referral plan that we also get from the primary healthcare facilities to the tertiary healthcare facilities. So we tend to follow the standard treatment guidelines that we have within the country. And also the strategic plan that was initially presented, they had different objectives of which we are, as healthcare providers, try to achieve them by the help of the Ministry of Health. Next, please. There are different models of providing services among these individuals with chronic non-communicable diseases, and usually it's a long-term process. So once the individual has been diagnosed with these complications, usually we tend to delay in our settings. But through early diagnosis of the disease and also identifying the different complications, it's like a cycle of how we manage this patient. So we'll tend to start treatment early on, as well as continue monitoring these individuals through either scaling up of their schedule through the process of care delivery, monitoring the progress of the disease, as well as adherence to this medication. So it's a cycle that involves long-term management and disease control among these individuals. Next, please. So briefly, I'll take you through a case report of a 63-year-old male who was diagnosed to have diabetes and hypertension for more than 10 years. But recently, about 3 years ago, he was also diagnosed to have kidney disease. And we see that he has to attend a Wednesday clinic due to his diabetes and hypertension, and a Friday clinic due to his renal problems. But he was started on dialysis through the help of the NHIF, whereby he receives his dialysis on alternative days. Medication-wise, we follow the STG guideline on how to, on the different medications that are provided. But through the NHIF process, it's easier for this individual to adhere to his medications and also follow up clinics during the appointment times. And he also gets ongoing counseling on the diet as well as adherence to medications. Next, please. But the real picture is that once an individual has NHIF, we see that they'll adhere to their follow-up management of visits to the hospital, which is about 3 to 6 months. The appropriate follow-up investigations will be done, and also good adherence to the medication, as they will receive them from the NHIF insurance. But if an individual is self-sponsored, we see that there will be some gaps or hiccups within the follow-up of their management. There will be poor follow-up visits, as they'll complain that they didn't have financial support to come to the clinics. There will be poor drug adherence, as they will tell you that my medications are very expensive to to adhere to their medications. They'll present with multiple complications due to the poor control of their diabetes, as well as will have to involve the social welfare in the management of these patients. So this is the different individuals we get within the services that we provide. So as we talked earlier of these prevention challenges, we have the infrastructure challenges, we have economic challenges, demographic challenges, as we see that we are still getting elderly population, together with managerial challenges due to these planning processes. Next, please. So this is my last slide, whereby, before this one? Yes, this is my last slide, whereby prevention, as we have all talked about, is better than managing these individuals. And it's like an onion process, whereby we have to start from the family level before we go to the population and globally as well. And different organizations are also involved in the management of these patients. Thank you.
Thank you. So thank you so much, Dr. Nyesatu. And can I call all the presenters in front, please? And while they do so, the audience prepare your questions and some, questions, comments. So can we all stand up? Yeah, thank you, thank you. Get seated, please. You'll agree with me, these were very extensive presentations. We wish we had more time to listen to them and look at different presentations. So now we are going to get some few questions. But before we start, I have some questions for the presenters. So starting with Valeria. So we have seen a very nice strategy on NCD from the Ministry of Health. And also we saw there's still very little funding on NCD as from the presentations. So we would want to know what are the strategies that the ministry is marking in order to improve funding on NCD. We have seen your resource plan, but also it will be good to share on how much has been budgeted in this new budget that we are starting. We have started this week on NCD. So Dr. David, 8% of population only insured and 21% of the fund being used on NCD. And this has doubled in 2 years, so that's quite scary. So any actual study that NHIF has conducted to see on what will be the impact on the fund if this keep on increasing. But also, we know on our health insurance, we don't pay for screening and some of the prevention programs, but we have heard that prevention is better than cure. A lot of money being spent on treatment. So is NHIF planning also to spend some few money on screening for those who are insured and some preventive services so as to avoid them to long-term complications that will deplete the fund even more? Also for Professor Kaushik, so in Dar es Salaam urban, from RMO, we have heard that especially the poor in the urban area, they are not insured, and it's quite very expensive to treat NCDs. And 70% of the health facilities in Dar es Salaam are private sector. So also you being member of AFTA in the private sector, what are the strategies that we are making to ensure that this population that is insured and also the poor, they can also access these services? As we have seen, most of those who are accessing dialysis services are insured clients only. And also TDA has been working a lot on type 1 diabetes, especially in supporting type 1 diabetic patients to get insulin. So we want to see if there is any investment on treatment of renal complication, especially the dialysis services through TDA. Dr. Norbert, so significant number of hypertension, diabetic patients in Tanzania, as we have seen from the presentations, are not well controlled. So we would want to get your experience from Germany. What have you done? I assume the situation is better. The diabetic control and hypertensive, the control is better. So what have you done in Japan so as to have people controlled, well controlled on diabetes and hypertension? And Dr. Nyasatu, lastly, so Dr. Nyasatu, how do you ensure that we have been, at CSSC, we have been working with Pharmaxis on quality improvement, and we have supported a number of health facilities in quality improvement. But one of the areas that we have felt difficulties is to make facilities conduct regular clinical audits that will ensure that healthcare workers are really adhering to the treatment guidelines. I know NHIF has a bit controlled it because they really look on the adherence to treatment guidelines, but for non-insured clients and other clients, like the treatment in the hospitals, some healthcare workers do not adhere to the standards, but the hospitals, especially the doctors, it has been very difficult for them to, conduct regular clinical audits so as to make sure that people really adhere to the standards. Any efforts that have been made in KCMC to ensure that doctors are really adhering to the standards, we would really want to get that. So I'll give each one of you at least 2 minutes to respond to that before we go to the audience. Thank you. Karibu, Valerie.
Am I the first one because I'm next to you? Okay, thank you very much for your question. You asked how much is being allocated for the Ministry of Health. Now, for our budget, as the government budget, speaking of health budget, it's super mixed in a way that you might not be able to find exactly how much is being allocated for the NCDs per se. So we have interventions like for prevention, for curative, and all that accounts for prevention and control of the non-communicable diseases. For example, for the last year, for the last financial year, the total budget of the government that was allocated for the health was 8 to 9%. So I hope I have answered it very well. Thank you.
Thank you. Professor Kaushik.
Yeah, thank you very much for your questions. Some of the questions are unanswerable, some are answerable, some are beyond our scopes. So I'll start with the first one. I think asking the ministry for the budget on the NCDs, I think within the ministry, I think because the NCD is spread over all the different directorates, probably unless they introduce a budget line within the ministry, with an NCD whereby the prevention, the medicine supply, all the components come together, we'll never know exactly how much is being allocated there. So it is a question of what is the proportion of the total budget which is being allocated to health. That will probably give us an indication of how much is going there. Second thing is regarding, you talked to me about Dar es Salaam and the role of the private sector. I think the private sector and the role of the private sector within the NCDs, I think private sector is doing quite a lot within the prevention component. But component of supporting somebody who does not, for example, in a private sector, the way I know, if somebody comes with an acute emergency, the principle is that you should manage that person, he should not be losing life, and if you cannot manage, then you refer. You see, so somebody should not die in your hospital because he has no money. And I think that should be the bottom line. Second thing is regarding the use of type 1 diabetes and the insulin supply. I think with the children with type 1 diabetes, hemodialysis as a component, I don't think we should be talking about hemodialysis. I think we should be talking about managing these children very well so that they don't develop complications and renal failure, because no donor will be able to support, and you can see from the figures which have been presented by NHIF that no donor can continue supporting you on a dialysis program. And just as you have seen that the funding within the non-communicable disease is very poor because it is a bottomless pit. Nobody knows exactly how much money will be required to attain what you want to attain. So I think we should be talking about better control, early diagnosis, better control, compliance, adherence, and a good follow-up. And I think that would probably prevent us from getting into the complication. But saying that managing or funding dialysis, I think might be a bit challenging from our side. I think the other important question which you asked was regarding the funding and the prevention programs. And I think prevention programs within NHIF or within the communities or wherever we are, I think we really need to have an emphasis on the prevention programs, because if we don't do that, and the prevention has to start from the schools. I think it has to start from the schools and from the learning education, and then from the workplaces, as example was mentioned from Germany, because if the workplaces and schools are covered, then you will find that you will probably definitely see a positive effect on the prevention which you can see. Thank you.
Thank you so much.
Thank you, Coordinator. I have two questions. Number one was about, we talked about the 21% of benefit payment going for non-communicable diseases. So what will happen if the situation continue being the way it is? Is there any study, actual study, which was done in? Actually, what will happen without contributions? The study which we have so far is talking about without contributions, and and the situation the way how it is, maybe the fund will collapse in the next 3 years. 2025, NHF will not be there. If no contributions, and we continue spending the way we are spending.
Okay.
That's why we are pushing for universal coverage so that so many people can join the fund, and then we can widen our base in terms of membership and financing also. The second question was about the screening for those who are insured. I don't think screening for those who are insured will help the country. I think we need to approach this problem in a broader perspective. Prevention, number one. Prevention is cure. Screening will help you to know early diagnosis. It helps to know the diagnosis early so that you either treat or you do something. But for the population of around 60 million, and you're talking about only 80% being under NHF, what about those 92%? So in such congregations or in such community meeting or a symposium, we should talk about in all populations. You talk about those 92% and you talk about 8%. So I don't want to to escape the question, but the issue is, so far, our actuarial studies haven't come up with a recommendation on screening the insured, those who are insured. They haven't. But to me, if you ask me, I think we should go for prevention. We are lagging behind in terms of prevention. The whole country, not those who are insured by NHIF. Thank you.
Okay, thank you.
Okay, thank you. Just I got the idea that I will just later. So first to my question. I think I had it in my slide, and I don't remember exactly the figures, but I think nearly there's no one in Germany who with hypertension or diabetes not detected, because everybody who meets a physician will be controlled the blood pressure and taking blood and or urine, and so you will detect them. A high number is treated, about 90%, and from this, again, 90%, there I have no exact figures, are treated well. And as I remember, for example, my own practice, we had for hypertension, there was no one with more than 160 to 90, and they took different medicaments, 4 at a time. But we treated until they finally had a nearly normal blood pressure. And this is possible. And I remember the times when I have worked in the clinic where we had these cases with blood pressure 220 to 140. I have, in my own office, I have never seen later. So the people are normally well treated. The same for diabetes. We have special, ambulances for diabetes, and they they try to get the diabetes patients to a level or lower. And 6 is normal, up to 6 is normal. And you see that this treatment is, I think, very effective. Thank you.
Thank you, thank you.
Thank you for your question. And we see that we experience difficulty in having these, following the standard guidelines. I'm sure there will be other opinions from the floor. It's that we do not have a good database among our patients that we have in the clinic. Once we have a good database of these patients, we'll know where our gaps are and how to interact with these gaps that we get. But the standard guidelines that we have, the national guidelines, we tend to follow them. And mostly in our clinics, we tend to stick them on the wall. Let's say after 3 months, the patient should have this done. Or after 6 months, we should do this. But if you have a good database, it's easier to follow up these patients to see what has been done, what is lacking, and where the gaps are among our patients. Thank you.
Thank you. Okay, so now I know the audience, you have been waiting to speak, so I will welcome a few questions. Maybe to start with, we'll start with at least 5 questions, and then we'll respond and then proceed. Anyone with a question? So we start with RMO, then Mr. Pamba, and then Dr. Okay, and then you'll be third.
Thank you, moderator, and thank you for all our presenters. The RMO is not required to ask you questions, just to give advice. That's my law. So what I'll be speaking, just giving advice and advise also the presenters to take the contribution from the floor very seriously, because some contributions can be informative to add on what has been being implemented in the guidelines or in the policies. First, I would like to advise you on the importance of investing more in research and development in this area, collectively, jointly, our partners who are here, our delegate from Hamburg, and you can see most of the data. The presentation have been referring to data that more than 10 years old. So all the current status with a rapidly growing population, rapidly growing lifestyles. Not bad to have spoken a lot about cancers and so forth and data, but we haven't seen very clearly the data regarding the trend of cancers. The situation is very worse in our setup now. So that's the only area of my first area of advice, that please can we join hands together. Delegate from Hamburg, all the implementing partners in this room, the academias and so forth. But the other suggestion is on prevention. Professor Kaushik, on your last slide on the way forward, you emphasized on focusing on prevention, especially at the primary healthcare level. also know about the same. The prevention is something that is cost effective. We should not, yes, I'm not saying that we should not invest on a curative, but prevention is the best. And every presenter emphasizes on the prevention. And what we have learned from Hamburg, even the insurance scheme is also used for prevention part. When you are talking about screening and early identification, you're also focusing on the prevention. So my advice to the NHIF, it's not necessary that you provide the answer here. You can take it and maybe the point can be a point of discussion in your management meetings. It's not necessarily saying that, but it's very important, because when you are saying that what proportion of people who are insured, if we focus on this small group, in this segment, will it help? There are other interventions, focus on the general populations. But let me tell you, we don't have workplace program for non-communicable diseases. That's the problem. But most of people who are insured via NHIF are the ones who are, most of them are having hypertension, diabetes. When you come to my office there, 100% of people have been insured. Due to stress, their lifestyle, they don't have choice in terms of nutrition. 90%, they find 50 to 60 or 70%, they have non-communicable diseases. So we should not underrate this group that is insured. And most of people ask me, why, when I'm going to the S facilities and need for general checkup, the insurance does not allow that. So that's the point that you have to take. Yes, if we are focusing, even the national strategic planning for prevention and control, that strategic plan started with already prevention and control. So the intervention that we are putting has also to align with the national guidelines. So my suggestion is that we should focus on the prevention. The NHIF, the other insurance schemes also has to focus, has to have input on the prevention. And to my guest of Anna, I think we can have a chance, maybe in the future, to analyze the budget allocated for non-community, at least the government budget, starting from the lower level, the council, the facilities, planning for always have their annual plan and budget. So I think we can extrapolate the way, because we are the region, we also scrutinize those budgets. We assess them before submitting to the national level. So allocating the interventions relating to prevention, care and treatment for NCD, we can have at least you have that figure. Because going directly to the expenditures, what really has been planned, out of that has been planned in terms of cost, what extent has been disbursed for NCD intervention. So we are missing a part of budgeted amount vis-a-vis released fund by the government or so forth. I should not take much of the time, but Professor Kaushik, you were trying to relate at the NCD clinic, at HIV clinic. So does it mean that these diseases also relate? There are some associations that if you find somebody who have hypertension, is there association with the HIV also? Because we are taking some parameters, these 3 parameters, comparing different clinics and concluding the trend of each disease. Because we have been focusing nowadays on TB, HIV. These co-infections have some relations. But now we are now coming up with the non-communicable diseases. Apart from its effect on using medicines, are there some direct associations? Thank you very much for that.
Thank you. So, Mr. Pamba,
thank you very much,
please.
Moderator, and I'm glad, I really appreciate it for all speakers, the way you have taken us through. We have been learning, but also some questions we have noted. The other one has been preempted with the RMO. That was also my concern. I think what I was trying to see, based on our country, where are many people living really? Where are they centered? If you take really the structure of the country, we find many people at the level of the street and the village and the ward level. But link also to the services, the way it is set. At that level, you are talking about the dispenser and the health centers. Am I right? If you go for this is the closeness, distant for the people whom you think they have to have that access. Now, what I was thinking, how is it set the sensitization maybe Valeria, it can be part of the ministry, at that level, to help people for the preventions, to early cross-checkup of their problems. But how are they prepared also, the dispensary and the health centers, to take care of that? Because this is very important as well. Because we can sensitize and many people can work, and they decided to go to get that service. Are they prepared also to that? With this mechanism of problem of the experts which we have in their country at that level as well. I think there is a need now to see how do we structure that. It is very important because when I was checking the numbers, the prevention, the ages, I was saying, we have a big, we have a big task on how to go about it. I was also asking myself, why are we managing as a country to go now for education without a fee? We have gone to another level for Form 6 level. Is it possible that to be workable on the part of the health sector as well, the country to rethink differently, to see how we can help our people on that mechanisms? I think we need also to see. There might be some possibilities, but how do we propose it based on that, on how to help our people? And the other component, I was also trying to think myself that, okay, we are trying to help our people in that circumstances. Do we have a mechanism to have some different sources contribution from the level of the villages to support the health financing at that level? If we divide in that levels to different places, so that to see exactly how percentage are set on that to help. Because always I hear people are supported to economic perspectives. Some percentage are set aside to level of the councils. What about the other part component of health sector to help? Do we have that mechanism to help really at that level? Because I think we need also to think differently on how to help our people to that level. This is my concern, and this is, thank you.
Thank you, thank you. Please be brief on questions. Okay, Dr. Anya.
Thank you, I'm Dr. Elisha Osati. So I've been preempted by the RMO and the previous speaker, but from Germany, it seems PSA is not used anymore in screening for prostate cancer. I don't know what are the methods you are using. Are you using the DRE or the ultrasound? And it seems in Germany, as RMO said, the screening is included in the insurance package, the screening of NCDs. What about in Tanzania? But Dr. Mwenisano, you just said it is offered to the corporates. What about the healthcare workers who are attending the corporates? And the others actually. And what is the strategy towards including the screening to the health insurance package? Because we have been saying that preventive is better than cure. And on the universal health coverage that we are now talking about, I don't know who directed to, maybe they're from the Ministry of Health, but also Dr. Mwenisano can answer this. The universal health coverage in our country, it has been like 6 years now we are talking about this. You can remember during the first part of the current minister, Madam Umi, she brought the bill to the parliament 3 times, and it was not presented. Again, the previous minister also, it was tabled to the parliament, but again, it was not discussed. And we are now talking about that we are really want to go into. Is it the universal coverage in our country? This is a point of discussion. I know Harry, you are here. We have been discussing this for quite some times. Is it a reality or is it just a myth? Are we really going to it, to the universal health coverage? And I think in this meeting we have think tanks that we can discuss and see what are the drawbacks of the universal health coverage in our country. And we also understand from the TASAF, but about 20% of Tanzanians will not be able to pay or to enter into a universal health coverage. What are our thinking on the alternative financing for this 20%? We previously proposed to have the health fund that we can the health fund that we can take the sin tax and other contributions to make up the health fund, so that to cater for those 20% of Tanzanians who will not be able to pay. What are our reaction about this, especially the universal coverage? It is a point of discussion. Thank you.
Thank you. So take 2 more questions before we respond. Okay.
Thank you. My name is Fadhili Hezekia. Now speaking from the farmer's point of view and the contribution towards NCD prevention, I just was thinking that maybe from the ministry level, where have we placed the role of pharmacies? Since from many studies it has shown that pharmacies are easy to be accessed by the people around those areas. So I believe pharmacists, pharmaceutical technicians are already healthcare professionals, trained well, so they can be used considering that also we have low health-seeking behavior unless until we have an actual illness. So by the time they come to a hospital, maybe they're already into complications. But using the pharmacies, maybe we can educate the pharmacists, the pharmaceutical technician, to always talk about NCDs to whoever they dispense, to whoever they interact with. And speaking on that, maybe this to say, in November we are expecting to have an AGM, so I invite all the participants here, and maybe we are going to communicate with you that officially that we have this scientific conference. You can come and we help empower these colleagues and let them go and help the Tanzanians. On the other aspect of the financing, especially on the NHIF, I don't know, maybe it's my perspective, but I've seen a challenge of price of pharmaceutical services and healthcare services in Tanzania being wedged against the NHIF price list. And this has become a problem to those who are not insured. It is fine for those who are insured, and it is good, the agreement between the fund and the healthcare providers. And I do not, by this comment, I do not want the NHIF maybe by any means to go and redo the discussion, but I'm trying to say what is the role of the ministry now to make sure that the NHIF price does not make those who are not insured suffer, because the price in the market, in the normal clinics, pharmacies that are not directly related to NHIF, sell to them with the NHIF as a benchmark price. Thank you.
Thank you, Dr. Erimara. And okay, then Dr. Mara.
Hello. Yeah, my name is Dr. Shadrach Mwibambe. I'm a trauma surgeon. Personally, I have just have an advice to the Minister of Health, and my advice is a bit selfish. As I said, I'm a trauma surgeon. For a long time, trauma and injuries didn't have any platform to be addressed. And the trauma is a problem, is a big burden, causing mortality and morbidity. And very unfortunately, is to the young productive age. It is over recently now injuries, trauma are part of NCDs, so it is NCDI. So I wonder, a person from Ministry of Health doesn't address at all in the case of injuries. So it is high time to join the alliance. Addressing trauma as a burden, people should fall from the Ministry of Health. It will be the key to address people that nowadays trauma or injuries are part of NCDIs. If any others are going to fall from you. Thank you.
Thank you, Dr. Erimaru. And then we'll hear some responses and go for the last round of questions.
Asante. Erimaru from Farm Access. Please allow me to share a very short story which ni ya ukweli and relate with what we are discussing here. 2 months ago, my co-worker gave me a call that his father is sick and asked for advice. So after I heard about the challenge, I advised them to go to the hospital. And they decided, because it was already 6, so they went to a nearby dispensary, and the dispensary was closed. It was a public. It's here in Dar es Salaam, actually. And a clinician there agreed to go home to provide care to the father, the patient. Later on, she sent to me a message, asked me, like, where can I get this medication? Because I cannot find in this neighborhood. And then she told me, I've already got these others, only this one remain. In that prescription, there were 3 antihypertensive prescribed to a patient who was diagnosed for the first time with only single blood pressure check. Only blood pressure check at home. So I've not practiced medicine for 17 years, but I don't think medicine have changed to allow such kind of prescription. So my point here is, we can talk of prevention, which I completely agree that that's very important. But the second area, if you want to address the issue of financing for NCDs, we have to make sure that our clinicians adhere to national standard treatment guidelines. Because you can imagine, if that is how he has been prescribing to all the patients, how much we are losing in terms of money, which goes for those who actually were not supposed to get those medications. And I think Dr. Valeria presented here, 55% of their budget annually, of the 2.3 annually budget, is going to the medicine. And probably out of this, we have probably 50% which goes in this kind of patients. So I think that's a very important area which I think we have not taken much of our attention. I have another example of the project we did with KCMC between 2016 to 2018, but I think due to time I won't go there, but I can share during a break. Second area I want to comment is on financing model. So I start with those who do not have insurance. I think for now our policy is clear that financing of chronic conditions is free, which I believe we all agree that the model is not working. And it's not working because it's a supply-based model of financing. So my opinion is we have, as stakeholders, start to advocate for government to change from supply-side financing of chronic conditions to the demand-based financing of the chronic conditions. Because this is where we see transparency. This is where we will reach all those who really need that services. And my last also related with the financing with insurance. I've heard that, I think in presentation, Dr. Manesano, my colleague, and others referring to this universal scheme coverage or mandatory law. I think if you go to the Google and Google how many African countries have mandatory health insurance act, there are not less than 8. But how many have reached even 50% of coverage? Are only 2. And of those 2, Ghana, which has 50%, 40% of them are paid through VAT contribution. So those who pay themselves is only 10%. So the point I want to make here, we should not think that just having a mandatory act is going to be a silver bullet. There is a work which has to be done behind it to make it a reality. Last point related also with insurance. I'm not sure how Dr. Vareli and your team, you are involved in this ongoing discussion on universal health insurance, a minimum benefit package, and so on. Because what I've seen, although I've not been involved, but what I've heard, we are more likely going to crowd out low-income earners because of the premium we are going to set. If you ask any actuarial, and I think we have seen even the presentation from Dr. Mwanisano, in any insurance premium, which they calculate now, the actuarials, 15 to 40% of the premium is to cover chronic medications. Meaning, if you remove management of chronic in a package, you can reduce your premium by 15 to 40%. So if you look at the actual example now, if you have that 40% in the premium, you will end up to exclude all those who are low-income earners, and few of them who will pay, who do not have, few of them who will pay will end up to subsidize higher income earners who have chronic medications. So even if government put in a subsidy, government will be subsidizing those who can pay, who can afford to pay that premium, and left or crowd out those who cannot afford. So I think despite discussion in introduction of that minimum benefit package, we should advocate for government subsidy to the chronic medication treatment. Thank you very much.
Thank you. So we'll allow now the presenters to respond to the comments and questions. Please take 1.5 minutes each. We're running short of time.
Thank you. It's even better if you say 1 minute. Yeah. Okay, thank you very much. Now, going straight to the question, how is the ministry being prepared, or the system being prepared for the prevention and control of the NCDs, especially at the lower levels where our majority are located? First, we have the regional and the council district non-communicable diseases coordinators. These are responsible to look after their regions and after their councils, and they're also responsible to do the trainings to the healthcare workers who provide services at the lower levels, such as the health centers and the dispensaries. So even in our trainings, we train them. We have our master trainers who trains them, and then they go down and train the health centers, healthcare providers. And how are we prepared on how have we strengthened our services as in prevention or controlling? Now, speaking of our new strategic plan, we have decentralized the health services provided at the health centers, where before we did not have the non-communicable diseases at these centers. If they were found, they were referred to the higher levels, the districts or the regional or the higher facilities. Now, since we have decentralized and we have taken a role to do the training to our healthcare providers at these centers who provide the non-communicable diseases. So you can see that we train about 4 healthcare providers at each health center throughout the country, and this is done with a very good support with TDA, together with other partners. Even the CSC has also come to us, and we are planning to have our training to their facilities. Even PATH, we're also working on this. And I also call upon other partners, if you want to do training to the healthcare providers, you can also come and join hands with us. Also, apart from that, even at this healthcare, at the health centers, we also have our medical doctors being placed at those levels, because before we did not have people of that capacity. So even the medicines, some of the medicines were not even prescribed at that level, but now they are prescribed since we have people of that capacity. I mentioned about the trainings. I also want to comment, and thank you very much, Dr. Mfaume, for your comment. We can have a lot to work on how to do the calculation for how much is being set and how much is being used. And coming to the issue of survey or research, as the country, we already have a national non-communicable disease agenda. It's a very important document that we can all go and look at the areas, the thematic areas where we want to do our research on the NCDs in the country. And for this year, you can imagine we have the very outdated data, like 2012. We're supposed to have steps at least after 5 years, but now we are going to have another step this year. And speaking of this, I call upon all of you, all of the stakeholders here, you're all going to use this data. And we have a gap of $120 to complete the step survey. We already have the 400,000. So I call upon you and request to come and support and finance this step survey. So please do not let me down. And speaking about trauma, thank you very much for your concern. We have our national strategic plan talks about trauma. We have interventions, and you can even see how much we have decreased the cases of the injuries and road accidents after the interventions that are being put. But we, at the ministry, at the program, we also have a coordinator for the trauma. This is a new one being transferred and joined us just about 3 weeks ago. So we call upon you to come and join with us to intervene and to do the implementation together. The comments that was made by the person from Novododisk, okay, well, we would also take on board the pharmacist as well. Yes, maybe I can stop there. Thank you.
Okay, thank you.
Yeah, thank you very much. Aremo had one question regarding how was HIV and NCDs related. Basically, I think there is no direct biological association, but what you are finding is that in patients with HIV and TB, especially TB and diabetes, there is a comorbidity there. In patients who are poorly controlled with diabetes get more TB, and those who are TB, you tend to get patients with diabetes who have not been diagnosed in the community. So that's why we want to screen them for diabetes in TB clinics. And then for HIV, it is the antiretroviral drugs which are contributing very significantly by either direct toxicity of the drugs, or it's because of the poor viral load control, or it is direct toxicity of the HIV virus which is causing the problem. So there basically the NCD, many of these HIV patients are now dying of non-communicable disease rather than due to the HIV and opportunity infection. So that's the reason we would like them to be screened in HIV clinics. Second component which was there was regarding the primary health care. And I think the community and the prevention component needs to start. The question which we had is at the primary health care. And I think within the training component which we have within the primary health centers, we are trying to also enlist the community health workers, because we think that community health workers are going to be the key if we are going to pass on the messages on prevention at the primary level. And community health workers and at the primary level at the health centers, that is where we need to emphasize on component of early diagnosis and prevention. And finally, talking about UHC, I think UHC, as Dr. As has been mentioned, I think this has been a long going on story, and it has not come to a conclusion anytime. But most important thing, I think, is we have to think outside the box. We need to have some sort of an innovative financing mechanism which is going to basically help us to achieve those goals. And most important is that I think we do not have appropriate protocols of care for different levels, which you mentioned, is that people are being prescribed drugs which they should not be prescribing at a different level when there's a first diagnosis. Also, we have a standard treatment guideline, but for a primary health care, a simple algorithm tools, whereby you have protocols of care that if you find a person with diabetes, first diagnosis, or hypertension, first diagnosis, this is what you do. This is what you do. So I think the issue here is question about how do we actually implement those protocols of care. And those protocols of care can be costed. And once they are costed, then you can know overall cost of the treatment you are providing based on the numbers you have. So I think that is where we are lacking, that those protocols of care are not being costed. And if you follow those protocols of care for major top 10 diseases in NCD, I think we'll achieve quite a lot. Thank you.
Thank you. The issue of medical checkup and screening came up again for health workers and insured individuals. Let me take it for further analysis, and then probably we'll put it also to our colleagues who are doing actual analysis, and they will tell us how much we'll spend in terms of expenditure on medical checkup for those who are insured by NHIF. Probably we are just, you know, sometimes you can have a fear of unknown. Eh? You fear probably if you allow, you may end up depleting the fund, but it may be the other way around. So further analysis are needed on this area. The issue of universal coverage, consultations are still on. And the way how it has reached to the point, Member of Parliament already consulted, then National Executive Councils for Chama Cha Mapinduzi are already also consulted, and we are very much sure by September probably it will be able to be read in the Parliament for the first time. Now the issue is, the first thing is act. Second is maybe to have minimum benefit package. And then it's a process. So slowly you start by, maybe you can tie it with some services. If you want a passport, then you have to show insurance. If you want to have business license, then you have to show your health insurance. If you want to have a driving license, in that way. And those corporates or companies which government have some percentage in terms of shares, they will be also forced by law to join or to have health insurance. So for those who are, I think less than 20% who cannot afford to pay, then government will have to pay for them. But it's a reality. I can assure you, Dr. Osati, it is a reality. Where we have reached, it's a reality now. Thank you.
Thank you.
Okay, thank you. First, the question I got is about the PSA testing. It has abundant cost, the operations and what have been done only by induced by an elevated PSA caused more damage than it was useful, and so. At the moment, the prevention is palpation, sonography, if there's something not okay, and then punction and histology. And PSA is only used for if you treat, if you find a cancer, if you treat, then it is used for monitoring. So this question. But I want to add one other thing about screening. It's really important for me to say that if diabetes doesn't cause any pain to the patient, hypertension in its early years, it doesn't cause any pain, and so if you don't screen everybody who goes to a doctor for diabetes, which is cheap, you do a urine analysis, or for hypertension. You measure the blood pressure, it's also cheap and should be done to everyone. If you don't do that, you lose years. I think estimated 10 years where you could treat, and if you don't do this, the hypertension will cause damages to the body, the diabetes will do damages, and you can prevent them, and if you do a screening. That's why, really, for me, it's an argument to screen everybody as early as possible.
Thank you. Dr. Nyasato, do you have anything to respond to?
No, thank you.
Okay, so I'll allow one last round of questions and comments before we close, because we are way. And then I'll give chance to our IMO. He has other committed. We thank him so much for. Yes. So it's just. Thank you so much for being with us. Yeah, it was a pleasure. We allow you to go on.
Tomorrow we're having an official visit by Our Excellency President Mama Samia Suluhu Hassan to one of the hospitals going to launch the building, the maternity complex. So I have to go there and make necessary preparations.
Thank you.
So I really apologize for not having with you now. Thank you. Otherwise, thank you very much. Thank you.
Thank you so much. So we'll give one last round of questions. Please be brief. We're way ahead of time. Yes, starting from there, then Mama Ongara.
Thank you very much. My issue, one will go to the Minister of Health. I think there's a need for involvement of other sector apart from health. I will cite one example. I have one researcher who did a research on cooking oils that are circulating the country, and found that I shouldn't say most, but majority, they did not meet the standards. And we know what we eat is what we get out of it. We are talking about cardiovascular diseases. We know the issues of cholesterol and the oils that can lead to such diseases. So I think we need to involve organizations like TBS and other organizations that are important to ensure that what Tanzanians are eating is appropriate and can ensure that we eat health foods to avoid such kind of diseases which are caused by what we eat. My second issue is to do with the practical experience also, as Dr. Harry pointed out on the clinicians. I have one co-worker, we work together, a certain guy, and his father was, his uncle, actually not his father directly, but was diagnosed, was tested for creatinine at a certain hospital in Mwanza, and he was referred to Dar es Salaam to come and start dialysis. Fortunately, another doctor at another hospital here in Dar es Salaam, let me speak it, at Muhimbili, decided to do to do further checkup on that patient, because the patient was so depressed. This old man knew now with dialysis, we know what it means with dialysis, very expensive, and he didn't have any insurance. So this other doctor decided to do further analysis, and he didn't put him on the dialysis, and he's still living okay, and up to now as I'm speaking, and meaning that if that diagnosis, from the first doctor, and if decision was made to start him on the dialysis, it would have been a lifetime thing. But now the patient is doing very well. He's just coming for checkup, and he wasn't needed to really go for dialysis. So it means that I think there's a need to also to ensure that our clinicians are properly kind of told what to do. Not to make decision with the first diagnosis, as Dr. Kaushik and Professor Kaushik and Harry explained about it. My other issue was, I don't know how best it can be, with the universal coverage, Dr. David. I don't know how much we are sure that if everybody is covered, then things will be very well. Are we sure that the percentage that is left, Because we know the percentage of people who are able to pay are covered in other health insurance, Jubilee, Wapi, everywhere. We have a bunch of people who are not able to pay, and we think that if they are the ones who will be in universal health coverage, then things will be better off. I don't know if that has been done, that study, that the percentage of people who are, I mean, Mama Ntilie and everybody, people who are selling where we buy our coconut in the Bigenge and every, are they the ones who will be able to really contribute and ensure that NHIF will be in a better position and will be well financed in the years to come? I'm not so sure, but maybe you have some issues, you know better about that. My fourth issue is to do with the behavior change, especially with our young people. Nowadays we see people who have graduated, young people, corporate guys, what, they drink a lot. I don't know if we've seen. But they do really, they drink. Maybe it's in the urban setting where we see. We don't know what is happening in the rural, but I think we need to really make efforts, because these are the ones who will come later on. They will come 40, 50 years, and they'll be the ones who will be having all these NCDs, and there will be nowhere. I mean, I don't know if we'll have this opportunity to talk about it, because you know how it is. I think we need to really make intervention to make sure that we provide education, as Dr. From Germany, you talk about saving your employees. I think we need to do something to ensure that education and prevention and changing behavior is paramount to ensure that we save the lives of the young corporate people who are really now growing up. Thank you so much.
Thank you very much. My question goes to NHIF. I would like to know the coverage of ICHF. And also I would like to know why are we not embarking on heavily on ICHF, improved CHF. And another thing, you say that you are going to Congo, Rwanda, I don't know where, when we have the coverage, actually, the coverage is 80%. And you go to Rwanda, where we know Rwanda, they are faring very well on community health fund. What is the motive of going to Congo, going to Rwanda, while we have a very low coverage on CHF? Thank you.
Thank you very much. I just wanted to say a little bit. It's on health insurance and universal coverage. Just wanted to say the communities, how do they receive this kind of an idea? Because we were raised in a community where afya ni bure, elimu ni bure. When they went to elimu kulipia and afya kulipia, elimu fared very well, but afya still lagged behind. And why? Because this person who is sick is incredible and looks like he's sick and poor. So I went to a neighboring country at one time, and I could imagine, you know, you tell someone that this will cost some money, this amount of money. You feel maybe it will come after 3-4 days, but it comes the same day with that amount of money, because in that place there was no elimu bure, or afya bure. It was just like that. So I was thinking that the efforts should go rather on educating people why they should contribute for this health insurance, so that they do it. I remember one day, a long time ago, not very long, but someone was sick and there was this CHF campaign. And someone said, okay, I'm not sick, I haven't been sick for some time. And then when they went sick, they wanted to have a cover, can I pay that money so that we can have our services? And they said, okay, we will treat you now, the next time you pay for the cover. But you see, the notion in our heads that AFIA should be given by the government, it should be free, is also eating some of our populations in that.
Thank you, Dr. Sekule. And then you'll be last. Oh, okay. Okay, I'll give one chance. Okay. Dr. Peter.
Thank you, presenter, for the good presentation. Mine actually is a dilemma, particular to Professor Kaushik and Norbert. We know that currently, and we've seen from Dr. Mwenisano about the budget that is being expended on dialysis. We know that that could be consume large chunk of money when it comes to non-communicable diseases if we are not really investing on primary prevention. So my question to Professor Kaushik, we know when it comes to acute kidney disease, it normally takes a short time when it comes to dialysis. But there is a dilemma on when it comes to chronic kidney disease, when it should be a cutoff point, because it's also consuming large amount of money. We know we normally prescribe dialysis when there is less than next stage for implantation. But now we've seen that someone could go up to 3 years, 5 years with dialysis. And that could also consume household level financing, and that leads to catastrophic burden to the family, but also to the health financing perspective, to the health insurance and the like. So I think that's the way also we should find or provide the guideline on how best we can go about it, although it's the dilemma.
Okay. Dr. Peter Risha, briefly, please. Dr. Peter Risha.
Yeah, mine is about the sedentary lifestyle, which contributes too much to the high burden of NCDs. We know that NCD's prevalence in rural versus urban, it is more in urban, but I presume also sedentary lifestyle is more prevalent in urban. Now, the reason is the situation is, it is very risky out there going for exercise, and we have incidences. So I don't know how the ministry actively engage with others to make, to create an environment which promotes people to do exercise. Another one to NHIF, the modality of payment, which is based on fee for service, probably encourages fraud. Because you know exactly, if I do this, I'll be paid this, and if there's a possibility of doing the most expensive treatment, I'll get more money. So would you also try to consider a mix like capitation plus fee for service?
Okay, thank you. I think we have, there's still many questions. Huh? Are you prepared? Okay. Then one here.
Thank you. I just want us to think, when we are talking of health financing, we look at the budgets, we look at what is going on, but really in NCDs, we are talking of behaviors. It's really the behaviors of the people which needs to be addressed, so if we have to deal with the NCDs. But when we are talking of financing, we are looking at the medicines, we are talking of the diagnosis, the equipment and all that. But we are not looking at how do we assist the people to change their behavior. And here I'm talking about the issue of health promotion. Health promotion, where we need to improve the knowledge and the understanding of the people that it's their behaviors which needs to be changed so that we can address this. We are talking of exercises, we are talking of diet, all these things, it's people's mindset which have to change. So how much are we putting in health promotion? Because if we put a lot in health promotion, it may look that, because you cannot count health promotion in behavior change. So we don't put money there. And this is really where we need to see, how can we do that? Because if we have put money there and people are changing their behaviors, this is a sustainable intervention. Because people will behave in the right way. Let's not talk of only the medicines and all that at that level. How do we start down there? And here I'm talking about community-based approaches. When we are talking of community-based approaches, we are going to the individual. Social and behavior change communication. It's not an easy intervention. Because to change people's mindset, it takes time. And you cannot count on that. And so that's why many people don't want to put money there. But I think this is a really intervention, community-based approach. And I can give an example, because the community itself, once they understand, they will do things which we are paying for, but they could pay for that. And we are not counting on that. So let's look into that. Community-based approach, social and behavior change communication. Let's put money there, and people, once they develop that behavior, it will be sustainable. Not that to go to dialysis, tomorrow you go, and another day you go. But if you can change your behavior, and you remain healthy, eating well, exercises, all those things, from the individual level, the family level, the community level, we can reduce this amount, because we have seen that mainly the medications, the equipment which is needed, it's the one which we need to reduce that. And that can be reduced if we really put money in health promotion. The other thing is, we have already talked, is that the professionals, are they really that ready to take action? People come in, it's a headache, just give a Panadol, and that is it. How are we going to do that? Anybody come in, we go the steps. All the steps in history taking and all that. Our facilities, we strengthened them that. It's the issue of human resource. Because if the human resource is not, doesn't have that mindset, that I not just give a Panadol for a headache, I need to do all this process. Why is this headache? And then finding out that if we don't change that mindset also of our health workers, then we are missing an opportunity. So let's put more money in those areas, and at the community level and the primary health facilities, because, okay, I know what to do, but do I have the equipment? If I need to screen, once I have screened, what next? So all these things need to be addressed. And these are in our policies, but are we operationalizing our policies? How are we disseminating these policies which have been developed? Because they have been developed at this higher level. But at the community level, just distributing the strategies and policies, expecting those health workers to read it and understand and implement. It's not easy. We need to do more of dissemination, and dissemination is going through what does this mean, what does this mean, so that they can implement, not just giving them the documents to read. So let's look also on the issue of disseminating policies, strategies, and that everybody understands, from the individual, all the partners, all the stakeholders. It's not just that the government people, they know, they have developed the policies, and you cannot involve everybody to understand. So we need really to disseminate policies and strategies. Thank you.
Thank you. So we have brief question from Mama Gradeline, and then there will be two there. So please try to be brief, 1 minute each. Yeah.
Okay, thank you. My question is about the theme of this session, that health financing for non-communicable diseases. If we are talking about health financing, we also have to talk about the funding. If we want to do screening or to do major interventions like German, we need money. So there's a need for advocating for more funding to the health sector. And this should be done by sensitizing, maybe lobbying to the government to increase the funding. If we have very inadequate funding, obviously you will not be able to do the screening, you will not have adequate equipment, and etc., etc. So that should not be understated. We need also to focus on the role of the government of increasing funding to the health sector. Thank you.
Thank you. So, at the angle,
Thank you very much. Thank you for the presentations and the discussions that have been going on. So I think we agree on some of the basic issues, that the burden of NCDs in the country is increasing, and curative services are more expensive, and most of our patients still depend on out-of-pocket payment modalities for the services that they need at the facilities. So if you sum up all of those issues, you find that for us as a country, and I think it's the case for most of the developing countries, prevention is more important than waiting to cure the patients. Now the question has always been, where do you put your prevention measures? So we have been discussing about the primary prevention, secondary prevention, and so on. But I think in the case of NCDs, we usually forget about the primordial prevention. And this is it's very important, because we need to insert or introduce healthy behaviors to our children while they are still young. What do they eat? That they should do physical exercises, they should not smoke, they should take alcohol, and so on. So once we introduce these health behaviors at the young age, there is a possibility that these children will be growing knowing that by doing so, they are helping themselves not to have the non-communicable diseases by the time they are 30, 40 years of age. So I think while we emphasize on all other preventive measures we have been discussing, we should also emphasize on a primordial level of prevention when it comes to NCD. Thank you.
Thank you. So we'll take one last question there at the end. Peter, okay. There.
Good afternoon. Well, actually, I won't be far from the two last speakers. My concern was also about the issue of education, which is a primordial prevention. From the data displayed, we see that like 70% of all the deaths which occur annually worldwide are caused by the NCDs. Now, this tells us that this thing is real, that people are dying, and NCD, what it do, it causes premature death, where people are dying from 40s to 50s and not 70s, 80s as it was before. Now, my concern is on the issue of prevention. Here is where everything can sort a lot of things, can save a lot of cost later. Why? Because if you remember the time HIV was a real thing in our country, a lot of effort was put on education about HIV. I remember when I was in primary school, like every teacher would talk about it in the street, in the radio, on the church. So we were afraid of HIV. Even now, if somebody say he has ukimwi, it will have some trait on the head, like people are afraid of it, and people are doing every measure possible to counteract that. even these sex workers nowadays, they make sure that they use condom. They know what they're doing is not light, but they're using condom. This tells that the education is really going into the people's heart. But if that the same way it could be used on these NCDs, like the government ikafanya as how it did on HIV back then, maybe it could help a lot to educate the people. Because here is to educate the people. As Dr. Nabbat said, people don't come with symptoms, with pressure and diabetes. So with education now, at least it will help the community to know what to deal with, to cut alcohol, to skip smoking and living healthy life, eating healthy diet. Then from there is where we can really help reducing NCD cost from the lower level. And this education should go on the primary school, secondary school, so to segment this knowledge to children, so when they grow up, at least it will help on them not to engage in these sedentary and bad behaviors. So this is the work of Minister of Health and all other sectors as well. You can see from our menu of breakfast, a lot of cakes are there, a lot of unhealthy diet is there, and we're here discussing about NCDs. So you can see how this is really a problem on our mind. Like it is on, it is on our mind, yes, but we are not really committed for that. You can see it. So that's what I'm saying. If the government, through the Minister of Health, could use those guys who promoted HIV back then, they could really help us a lot now. Because HIV it was a real thing, and people really get this knowledge in their hand till today. Even some, as I'm saying this, boys in their room, in their ghettos, they have this HIV test kit on their room. When they have a girl coming on their houses, they measure them first. So this tells how it was, how the knowledge goes into their mind, that they know how to protect themselves. So if we do this again to NCD, that could help us. So here, if you do well with the promotion, you will see the results, and you will reduce the cost of living, the cost of all this, we're talking here, the burden, the dialysis, it takes like billions of money per year, but it all comes from there. So, of course, if we're really serious into this, then we should really be committed from everything we are doing. And yeah, this actually is what my contribution. Thanks.
Thank you. So a lot has been comments, so we have taken them. I'm giving you 2 minutes each to wind up because we are way past time. 2 minutes each, please.
Okay, I had 2 questions. One was regarding the dialysis and at the point. So again, that boils down to, I think, the protocols of care, and at what level do you actually subject somebody for a dialysis? And I think those criteria, nephrologists are the best people to decide what should be our national criteria, or when do you refer somebody for dialysis, when do you basically start somebody on a acute or a chronic dialysis program, or whatever the case. So I think it boils down again to what Dr. Imambo was saying, was that the professional protocols of care and following the medical ethics, not just putting somebody on dialysis because you are getting one extra client on dialysis, it's probably putting on exactly at what criteria would you like somebody to go on dialysis. But I still feel that instead of talking about dialysis, we should be talking that patients should not be going towards dialysis. If we control them better with hypertension and diabetes, I think dialysis should be an end of the game sort of a thing. So I think we need to put more emphasis on primary and secondary prevention rather than going for dialysis. So it's a question of protocols of care. Talking about what Dr. Kimambo was talking about, I think what we are lacking here is the multi-sectoral approach. We are discussing prevention by Ministry of Health, while prevention is 95% outside the health sector. It is the roads, it's the schools, it is the finance, it is the economics, it's all those things. And I think we are not sitting down together with the other stakeholders to really plan out how do we want to approach this component. And I think that multi-sectoral push is not yet coming from where it should be coming. So I think that is where we have the biggest gap. Thank you.
Yeah. Thank you. There are some few issues to respond. On the issue of ICHF, ICHF is no longer under NHIF. It's in the Ministry of TAMISEMI, so I cannot say anything about it. The issue of opening up, we have embassies, staff, we have ATCL going to some countries, and we also have companies and some business people who have opened their business in Rwanda, Congo. They need to be covered. For example, there are so many, because maybe we are the one who are receiving the request. Just recently, CRDB went to Burundi, and we are serving people, staff of Burundi, CRDB in Burundi. They are going to Congo, will go there also. So also issues of medical tourism. We want to capture the Congo market, Burundi market. They want to come to Tanzania to get medical services. So we have to open up our mind. We should not just think of only Tanzania. We are also thinking of Tanzania in terms of universal coverage. That's why we want to open for more people to come, but we also have to go out of Tanzania and do business there. The issue of Dr. I've forgotten your name, but you talked about these mamantirie, small business, small and medium enterprise plus matching up, and those ones. If they come, will they boost our funds and be able to cover most of the services? You know, for social health insurance, we as I've already said, we are working on under this principle of social solidarity. So if you are many, you contribute, and then some of you will get sick and will be covered, compared to private. Private, before you come in, they have first to check you. If you have diabetes, get out. If you have hypertension, we cannot cover you. They only want to cover people who are healthy, different from these social insurances like ours. That's why we depend on the government to come up with the act. We come up with whatever they can do so that people can join health insurances, and then they get services. The last thing is about the modality of payment, fee for service. When we are going for universal coverage, for dispensary and health centers, we want to use capitation, and then district hospitals up to national, it's very difficult to do capitation. So we'll continue with fee for service. We are thinking of all those three: fee for service, diagnostic related group, plus capitations, so that we can continue being in a business. Otherwise, we'll get out of the business if we continue the way we are doing. Thank you.
Thank you.
Thank you. I got no special question, but let me make two remarks. I think some of these proposals are not contradictional to go to communities and to change the mind of people, and to go to the schools and say teach pupils that they shouldn't smoke and drink too much, and medical screening. This is not contradictional. You could and you should do both. But from the, for example, for diabetes and hypertension, please keep in mind that they will grow with the aging of population. And this is not only a question of alcohol, smoking, and so on, but if the population gets older, these diseases will increase. And so it's really important to do a prevention and an early screening.
Thank you all for your comments. As a clinician, we have seen now where the gap is, and mostly we need to concentrate on prevention. Prevention from secondary, from primary levels. And by addressing those ones, at least we'll reduce the complications that we currently see. Thank you.
Thank you. You all agree with me that we have had a very good discussion, and I just realized, yes, last comment.
Okay, thank you very much. what is being commented lastly is mainly on multi-sector engagement, as well as promotion and prevention, and focusing on the community-based approaches, as well as the social marketing on the better ways we can prevent the non-communicable diseases. But please allow me to comment a little bit on what's been done already by the ministry regarding the multi-sector collaboration. We already have the non-communicable diseases focal persons in most of the ministries, and we are soon going to have a meeting with them, at least to hear on what they have done so far regarding on the prevention and the control of the non-communicable diseases. But again, as I mentioned before, about the committee that oversees the HIV/AIDS, drug use, as well as the non-communicable diseases, on the last meeting that we had with them, as in presenting the program, it tasked and it ordered that the issue of the non-communicable diseases should be multi-sectoral. And then we send this to the Prime Minister's office, and it's also working on how to have a better coordination from the national level downwards the lower levels. But again, coming to physical activities, we already have the guideline on the physical activities and the sedentary lifestyle, and it's good that it's coming out from the stakeholders that a lot has to be done on dissemination. I really take it forward, and I'm looking forward to have the documents being disseminated across the groups. But it's good to see political will and different people being championed on the physical activities. Like for the moment, we have a number of many marathons, fun runs, like the one we had just last week. We had our Honorable Minister, Mama Umi Mwalim. She participated in the Moi Marathon. We even had the Figo Marathon. It was also done on the Figo commemoration. It's even coming from the Parliament. We even see our Speaker, Mheshimiwa Tulia Ackson. She's the champion. She does these marathons, and she calls upon many people to engage. So I see there are many potential opportunities that we can grab and put them in place for prevention and promotion of the non-communicable diseases. Thank you very much.
Thank you. So you agree with me, we have had good discussion, and maybe one day is not enough. So different stakeholders here, maybe we'll think of organizing a bigger one for 2 days. Thank you so much. So as they go back to their seats, please, we all stand up and clap for them until they get to their seats for the great presentation. Thank you so much.
So you may get seated. So once again, may I thank Dr. Kwai for moderating this session, and the panelists for the very insightful presentations. It has been really educative, and we hope that we got some knowledge and how we should handle the issue around the NCDs. So from the discussion, two issues came up. The issue of prevention, that means the approach, and the funding. So CC is one of the partners. We've been very committed to ensure that we support the government efforts, initiatives to address the issue around NCDs. And as of recent, we managed to secure funding from our two important partners who are present here. We have the Meditronics Lab, who are supporting one of the programs with Afya Imara, basically focus on the prevention activities. So may I welcome the president from the Meditronics just to briefly share with the strategy that we are using through the Afya Imara program. Karibu sana daktari.
So good afternoon, everyone.
So my name is Dr. Oren Umbiro. I come from Medtronic Labs, where I lead the research and policy portfolio for the region. And I'll quickly talk to you about what the Afya Imara program is, that we are collaborating with CSSC as well as Sanofi with technical support from the Ministry of Health. So as the slides come up, I'll briefly talk about who Medtronic Labs is. So we are an independent organization headquartered in the US, but with a footprint globally across multiple countries in Africa and Asia. And here in Africa, we work in, here in Tanzania, we work in Rwanda, we work in Kenya, we work in Ghana, we work in Sierra Leone, largely doing NCD programming. So NCD prevention, NCD screening, and prevention and control services. So we look at the entire continuum of care from when a person is screened all the way to control, as well as strengthening data systems. So far, since 2018, we've been able to reach and screen over 230,000 people for diabetes and hypertension across the 5 countries. And we've been able to enroll into care over 100,000 people living with diabetes and hypertension so far. And we've been able to train over 3,000 community health workers as well as healthcare workers across the 5 countries, largely focusing on primary health care facilities as well as community health services. Next. So I think I've spoken to this. So currently our focus, as I've already mentioned, is around non-communicable diseases. We started with hypertension and diabetes, as well as disabilities in Asia. And we are now moving into mental health, and I'll speak briefly to that. And I'll not belabor much about why we are investing in NCDs. I think many of the speakers have mentioned about the global burden of NCDs and their contribution to the economic burden in the health sector. I think I've also spoken to this. Next. Yeah, so how does our model and approach work? So we combine digital health solutions. So we leverage on a digital health platform called Spice, together with services as well as point of care diagnostics to improve access to screening, to care and treatment services, and strengthening of data systems. So how does it start? So I'll walk you through the patient journey. So we start with screening at the household and community level. Here we train community health workers. We give them an NCD kit that has a blood pressure monitor, it has a glucometer, it has strips, it has educational material and other consumables, and it has a smartphone with the platform, Spice platform or digital health platform therein installed as a mobile application. So when they go to the households or to a community event, they do health education and awareness, and then they screen. And for diabetes, there's a screening criteria. So once they screen, they feed the readings into the platform. Once they feed the readings into the platform has a decision support model that is able to notify them when the readings are higher than normal. So they are able to refer these patients to the health facility for confirmation of diagnosis. Now, once, if the patient does not get into the facility within 72 hours, then our team of telecounselors is able to call these patients and ensure that they are linked to care for confirmation of diagnosis. Once they get to the health facility, of course, they undergo a full workup by the healthcare workers who we've also already trained. So these healthcare workers are able to confirm the diagnosis, and the platform at the health facility where we've issued tablets, it has decision support tools and risk calculators. So like BMI calculators, it has the CVD risk score by WHO. So the healthcare worker is enabled to make the right decisions about the patient. The model also has a lab module. It also has a pharmacy module where the healthcare workers are able to dispense medicines through the platform, and we are able to routinely monitor prescription and dispensing data. Once the patient goes back to the community, they are followed up by the community healthcare workers at home, where they get a blood pressure reading, a blood sugar reading, weight, and BMI calculated, and this is still fed into the SPICE platform. And if these readings are higher than normal during the routine follow-ups at home, then they are referred promptly back to the facility for either change of management or escalation of the dose or any other intervention that is required, so that the patients don't have to keep going back to the facility all the time for their blood pressure and blood glucose reading. And the frequency of monitoring is also determined by what is prescribed by the healthcare worker. So we also have other patient support services, such as telecounseling, as well as patient support groups, to ensure that the patients constantly get support for that. In addition to that, we have increased data availability. So we have real-time data analytics generated by the platform at both individual level as well as at aggregate level. So like what you see in the previous slide, please. Yeah, so you are able to, at a glance, see the longitudinal tracking of a patient over time. This is for blood pressure, but we also have blood sugar and other readings. Next. And then we have also the aggregate data. So we are able to track from screening to referral to diagnosis, enrollment into care, retention in care. We are able to track assessments. We are able to track treatment status as well as control and even complications. And all this data is disaggregated by condition, by sex, and other socio-demographic factors, risk factors, health insurance status, and all this to support the tracking of national and global NCD targets, including the recently endorsed global diabetes targets. Next. So coming down to the Afya Imara program, which we are implementing together with CSSC, Sanofi, with technical support with the Ministry of Health. We started implementation in February this year. We are covering 21 faith-based facilities under the umbrella of CSSC across 4 regions. That's Dar es Salaam, Morogoro, Arusha, and Kilimanjaro. The program has a target to screen 76,000 people for diabetes and hypertension in the next 1 year, enroll 16,000 patients into care, and achieve control for at least 50% of them. Next. So far, what have we been able to achieve using this model? We've been able to screen 20,518 patients, persons for hypertension, 27% of whom have been found to have elevated blood pressure and referred. We've also been able to screen 20,025 people for diabetes, 13% of whom have been found to have elevated blood glucose and referred. Next. So in terms of enrollment, we've been able to enroll 4,613 patients into care, 58% of whom have hypertension only, a quarter of whom have both conditions, diabetes and hypertension, and 18% have diabetes only. We are still seeing more females being enrolled into the program. Next. In terms of age distribution, we are seeing a peak in the age range between 40 to 59 and above 60 years. Next. And what is interesting is the BMI distribution of the enrolled clients. 66% of the patients who we've enrolled are either overweight or obese. And we are setting up a program to see how do we ensure that we have a weight management program, because this has a big bearing on complications as well as control. Next. In terms of treatment outcomes, so this is something we will be tracking, as I've already mentioned. The program is 3 months old. Most patients are less than 3 months old in the program, so we might not be able to report on the treatment outcomes at this point in time, but I hope to meet this group again in the next few months to comment about that. Next. So what are the key takeaways? We've seen that digital health platforms can support end-to-end longitudinal care and real-time data availability for planning, financing, and quality improvement. We've also seen the role of PPPs, public-private partnerships, in financing development of these solutions. So providing catalytic funding for some of these solutions, which can then be scaled up by governments or through official development assistance. We've also seen the role of task sharing or task shifting, for instance, using of community health workers to improve access to screening and awareness at community level, as well as follow-up, routine follow-up of these patients, so that we can let the healthcare workers focus more on the clinical work. We've also seen the importance of complementary patient support services, such as telecounseling, to complement the other traditional means, such as patient support groups and other means of patient engagement and patient support. Next. So what next? We are working with the Ministry of Health, and I know recently we participated in the validation of the new patient registers and tools. So how do we integrate these into the platform? We are moving into additional disease focus areas, such as mental health, and I know we will be having a meeting with the mental health team from the Ministry of Health tomorrow to integrate these. We are also looking at HIV, hypertension integration, and TB diabetes by directional screening. We are also looking at integration of our platform into existing platforms within the health facilities, as well as integration with the DHIS2, piloting in public facilities. We've already piloted in the faith-based facilities, so the next step would be piloting in public facilities, as well as doing a costing and cost-effectiveness analysis of this model to inform scale-up and health insurance conversations. So thank you very much, and looking forward to working with all of you to leverage on digital technology to improve access to prevention, screening, and management for NCDs. Thank you.
Thank you so much, Dr. Oren, for being so brief, and I think it's been a good presentation. So may I welcome Dr. Fadil for the final one. We are almost coming to an end of this session, so Dr. Fadil, 5 minutes, please.
Thank you so much. Good afternoon. Just to correct, I am a pharmacist. I stand in front of you representing Novo Nordisk, and for me to share with you what we have and what we work with CSC and together with the government. We have an initiative called iCare, I being small and care being capitals, C for capacity, A for availability and affordability, R for reach, and then E for empowerment. And all this is on diabetes patients. Novo Nordisk is a Danish company that has been working on diabetes and insulin for more than 100 years now. Despite that and other efforts, Novo Nordisk has noticed that majority of the patients needing insulin actually do not get access to insulin. So after some time and considerations, it has come to the mind of Novo Nordisk that the real patients who need insulin and not covered by insurance actually do not get insulin because they cannot afford. And we decided that we will partner with the government, we'll partner with CSSC, and try this small initiative and see if we can help these patients. Now, how is iCare structured and why it has come to existence? It's because like I highlighted in my comment during the panel, is that there are patients that are not covered, they need insulin, but when they go to pharmacy, insulin is benchmarked against NHIF price, which is 25,000 shillings, while the pharmacy actually get the insulin from the wholesale at a wholesale price of 11,000 shillings. That is very unfair, and so we thought we'd need to do something that will maybe set a base, and then the government can advise further and put down some policies. Luckily, the government agreed on the idea and supported, and we launched the initiative here. So capacity building will mean training the doctors, training the nurses, training the pharmacists, and actually the date for the training has already been set for this July. And this has come because, of course, our human resource also was and is still being limited, and we have a lot of staff turnover. They change department a lot, so you find new healthcare professionals in the diabetes clinic every time the patient comes. So that by itself makes a bit of a challenge in terms of not having a consistency of the care. So we will train together with Tanzania Diabetes Association. They will help us in training. On the affordability part, CSCC will help us, and also MSD will help us. MSD is already getting the insulin at a tender price of $2 and exiting MSD at 6,500. So we expect all the government hospitals to give insulin not more than 10,000 shillings, so that even those who pay out of pocket can get it at an affordable price of 10,000, not like now when they are getting it at 25,000. With CSSC through IMEMS, that is Improved Mission for Essential Medicine Supplies and Services, they get their insulin from Salama, also at a subsidized cost through an initiative that Novo Nordisk has launched. And that insulin will get to the facilities that has signed an agreement with IMEMS, CSSC, and Novo Nordisk that they will give at an affordable price. And also the price has been set not more than 10,000. So we believe the initiative will improve the affordability. And so those who need insulin will get the insulin. On REACH, we intend to go to all the CSSC facilities, and under the guidance of the Ministry of Health and PRALS, getting to the public facilities. And therefore, those selected facilities, HCPs will be trained, patients will also be given education under the last letter, that is empowerment. What we ask is for those who are already partnering in diabetes care to continue supporting the insulins to be affordable, especially if NHIF was going to be here on their part, but also the government is already taking it on board. And therefore, for us, the target is the low income people, old, aged people, and the patients that are coming out of the programs that Novo Nordisk is doing with Tanzania Diabetes Association. We have type 1 patients under the project called CDIC, Changing Diabetes in Children. But by the set of the program, by the time they get at the age of 21, they are rolled out. So when they are rolled out to nowhere, where the insulins are very expensive. So that's why we want to take them on board through the iCare, together with the other group that are vulnerable. They cannot afford these high-priced insulins. So thank you, and I believe for everybody here as a partner on NCD will also join us hands together with TDA, the Ministry of Health, the CSSC, to make sure that insulins are no longer in a luxury product for the diabetes patients who really need them. Thank you.
Thank you, Fazil, for the presentation. So I think now we are going to have the final one. As I said earlier, we started the commemoration for the 12th anniversary of the partnership between our two sister cities, Dar es Salaam and Hamburg. So today, I think this is the final day. So I would like to invite Sanjita as the coordinator for the final aid.
Thank you very much. I'm Sangeeta Fager, and I have a presentation also, but I'm not the coordinator of the partnership. This is Inken Bruns, my dear colleague, also at Diakonia. She's the coordinator of the Sister City Partnership. I'm just part of the health network, and this is where I'm active. So I would like to, or I have the honor to introduce the Health Symposium, the Health Network Dar es Salaam Hamburg. And next slide, please. So what is the Health Network? We are a combination of different players in the health sector from Dar es Salaam and Hamburg. And we have different areas of activities. So we have clinic partnerships, and partnerships between hospitals, like partnership between Amana Hospital and the University of Hamburg Hospital and the WIMS. Dr. Neuburger is part of WIMS. We have a partnership between Cardinal Rugambwe Hospital and Alsterdorf Hospital, which is a German-based organization. We have a partnership between Muhimbili Hospital and Altona Hospital, and we have a partnership with Temeke Hospital. Apart from the hospitals, we are part of our network is a FIA mobile network. Alsterdorf is an organization working with people with disabilities, but also having hospitals. Then, of course, the CSSC and Diakonia as umbrella organizations, which have a high variety of member organizations. Alsterdorf is a member, for example, of Diakonia. Cardinal Rugambwe is a member of CSSC, so there's an intertwining. The Evangelical Lutheran Church is part of our network. Igbo handicapped children is part of our network. Regional and city health offices are part, regional pharmacists, and we have also medical personnel and sister city coordinator in form of Inke Bruns. And we have persons who are just interested in the health sector. So all these people join together and make the health network Dar es Salaam Hamburg. Next slide, please. So what are our common topics? Common is the clinic partnerships, where we have exchange and where we have internships in clinics in Hamburg and in Dar es Salaam, and we have personnel exchange to learn from each other how the system works. We had and have exchange on insurance system. How does it work in Germany and how does it work here, and how can we improve from our joint and mutual understanding? We work on mother and child health and neonatal care, and as we are talking today, we do work on NCDs. And what is also very important in the health network is building awareness and building services for people with special needs, with disabilities, and to also work with their families. Our overall aim is to ensure the inclusion of poor and marginalized people, which sometimes don't get a voice on the high level. So for us, it is very important to always, when we start discussing how can we include people who are at the margins, how can we get them into the system. Thank you. Next slide, please. So, as I mentioned, we have exchanges and internships. We try to network via internet. We are exchanging information digitally. We have a roundtable in Hamburg where we work together and exchange our experiences. And thanks to COVID. We also started Zoom meetings, which was enriching because we could meet more often than we could meet in live. So there's maybe, with all its shortcomings, there is an improvement with that. And what we also work on is how do we find jointly financing for the projects we are thinking of. So because sometimes you need money to do some work. What I want to stress in all this is that it all depends on the really dedicated work of the individuals who are in this network and in this partnership. It doesn't go by itself. It's not organizations only partnering, but it's people partnering and their dedication to the issues of different issues of health where we want to work together. And it includes a lot of voluntary work. So a big thanks to the network going out and the network being here. Next, please. And I was asked to say something about the future. So what I can say is that the roundtable is growing. We are having people, more people interested, and we are trying to find new partnerships. We hope to build on what we have, and we hope to let the mutual trust and the engagement we have grow in future, and there are new things developing, but since they are in development, we can't talk yet because it's better to talk when it's reached. And we stay with the common goal, make health for all and access to quality services for everyone a reality. Thank you very much. Asante sana.
So thank you, Sangeeta, for the presentation. We have now come to an end of this symposium. So before we close, may I take this opportunity to thank every one of you, particularly the development partners who supported the financing of this symposium. May I mention Idanida, Novo Nordisk, Meditronics, Northern Church Aid for financing this symposium. It's really been a very good one, and we hope that this is just being the beginning of such partnership to enhance the coordination around the NCD. May I also thank the panelists, the five of them, Professor Kaushik, Dr. Nyasatu, Dr. Valeri, Dr. Norbert, and Mwansawa from NHIF for having such an insightful presentation. It's been really it's been a good one. We thank you for your insightful presentation. Also the IPs, the implemented partners who joined us in this symposium. May I mention the THPS, Tanzania Health Promotion and Support, Farm Access International, BAKWATA, AFTA, National Alliance for NCDs, AFIA Plus, AMREF, TPHA, that is Tanzania Public Health Association, Health Leak Initiatives, Benjamin Mkapa Foundation, Medical Association of Tanzania, Tanzania Christian Medical Association, CBRT, and Pharmaceutical Society of Tanzania. We thank you all for joining us also in this symposium. Also, we thank the organizing committee that has been working day and night to organize this event, and we thank you for all your efforts and time. We also thank the Hamburg partners, the local partners, Cardinal Rugambwa and Yamana, for coordinating different events throughout the week. It has been really a very productive week for everyone. So we thank you all for such coordination. Also, all the participants who accepted our invitation today, we thank you all for participating, and also the media people for covering the event. So this marks the end of this symposium, and we thank you all for your time. Now the last session will be photo. We have the group photos. Now may I request the all 5 panelists to come in front. We have the group photos. So after the session for photograph, we'll have lunch, where every one of us will have time to network, have one-to-one discussion. So may I welcome the panelists in front, please. Dr. Nyasatu, Professor Kaushik, Dr. Valeri, Dr. Norbert, and Mwansawa. May you please come in front. So the first group will be Dr. Norbert. So Dr. Valeri, the guest of honor, will be at the center. Where is Dr. Mwansawa? Professor Kaushik has left? Okay. Now the first group, may I welcome the Hamburg coordinator, Inken. Maybe also come in front. Inken. Dr. Balati and Dr. Kwai. Yes. Dr. Balati, Dr. Kwai will stand at the back. Yeah? Okay. So may I call upon the partners, the Noren Church Aid, Danida, Novo Nordisk, Meditronics, NCA, will stand at the back. So don't move the speakers. Don't move, Dr. Barati. just one few minutes. So we'll be followed by IPs, all the IPs. After this, group photo will follow. The IPs, the THPS, Farmer Access International, Bakwata, AFTA, National Alliance for NCDs, AFIA Plus, BMAF, AMREF, Health Links Initiative, MAT, TCMY, CBRT. May you please come in front. It's okay. You can now. Yeah. Thank you. Bado? Ah. Okay. Sorry. Watu wengi sana hao. Basi kwa tayari mniambie. Done? Basi naomba IPs wote tuje mbele. IPs and the Hamburg delegates, the rest of the Hamburg delegates. Mambo vipi? Tatosha? Hao wamekuwa wengi. Ndio kule mbele kule. IPs tuko wengi. Okay. The last one itakuwa CSC staff na other local partners wa Dar Hamburg Partnership. Naomba Cardinal Rugambwa na watu wa Amana and the rest of the partners. Na watu wa Muhimbili pia tusogee. Is that still mbele sasa bado? Is that
Dafür müssen die